Okay, Dr. Kahn, you have less than a minute and we are ready to have you call this meeting to order whenever you're ready, as soon as it turns 9 a.m. My count says it's 8:59.
Yep. So it's 9 a.m. I'd like to call the meeting to order. And I need to acknowledge that we do have a quorum present. So request Leslie to proceed with our quorum count.
Thank you, Chair. I will start with our voting commissioners. Dr. Kahn,
Present.
Dr. Barron,
Here.
Teresa Bohannon,
Here.
Babette Bond,
Here.
Jessica Flood,
Here.
Flo Kahn,
Here.
Dr. Packham,
Here.
Yarleni Roa Dugan,
Here.
Sean Shaner. Sean Shaner here.
Sean,
Dr.
are you good?
I'm sorry.
Checking if Sean is on mute.
Sean is here. I just, it looks like he might be having some technical difficulties.
Okay.
Okay. Dr. Slonim,
Present.
Mason Van Halling,
Present.
and moving on to our advisory commission members, Heather Korbulik.
I'm here.
Heather, okay. Barbara Richardson. Barbara Richardson here. Richard Whitley.
She's here too. She must be having some technical difficulties, but she is in the queue.
Okay. And then Director Whitley.
Same for Director Whitley.
Okay. Okay, Mr. Chairman, that concludes our roll call. We have a quorum.
Thank you. Welcome to all the commissioners in this new position that was requested by the governor to take on. So I would like to just have a few requests of the commissioners. If we can try our time limit on the meeting conclusion of some BDR recommendations is coming to a close. We have one more meeting before the deadline. So hopefully in the interest of time for all the commissioners and the interest of the deadline, we can focus on each item that we talk about and come to some consensus or by vote so that we can really move the needle forward from here on. So I would also request if those of us who have a point to raise, to please raise your hand. Sarah will recognize those at her end and let me know about those. Ideally, I would like to see all commissioners participate equally in their opinions and recommendations, and it would be helpful for all of us if we address the chair and if possible avoid talking to each other in our opinions or observations or issues. So having said that, I would move on to the item number 2 of public comment. Any public comments we have in the north?
Okay, Chair, one moment. Any of the callers, if you would like to speak during public comment at this time, please press *9 or raise your hand on the Zoom platform. Okay. Okay, Chair, looks like we've got a couple of public commenters. I'm going to start with phone number ending in 0523.
Yeah, and I would request if our restrict our public comments to 3 minutes each in the interest of time and the big agenda we have.
Okay,
Thank you, Mr. Chairman, members of the commission. This is Tom Clark. I'm here on behalf of the Nevada Association of Health Plans this morning, and I promised Dr. Kahn that I will be quick and efficient with my remarks. As you contemplate, and I've been watching the PPC meetings to date, the all-payer claims database, we just wanted to kind of get on the record some of the thoughts and concerns that we have as an association. We represent all of the private insurance companies here in the state, and we participated in Senate Bill 472 from the last legislative session. And I would encourage you to take a look at that bill and the minutes from the testimony that was provided as it was contemplated back then. One of the big concerns that we have is cost, of course. And then at that time, the cost was around $3 million. That was 2019. It's good to hear that the federal government was willing to come in with a 90-10 match through the Centers for Medicaid and Medicare Services. There was testified to that program may be going away. Hopefully that money is still there. And if it is, it's not just the stand-up costs in the first year that are of a concern, but the ongoing costs to the state and where those costs will be paid from. And that leads to the data. And what data are you contemplating is most important through the APCD. And as you look across the country, there's 18 different mandated data collections with 18 different formats. From the Health Insurance Association, we would encourage you to look at the common data layout. The CDL, as it's referred to, was developed by the National Association of Health Data Organization, and it is currently mandated in the Virginia program, and it's also going to be used in the California program. Basically, what that does is give the health insurance companies some level of consistency across the plans, because every plan has a different way of gathering and holding their information. And if the state is going to require that to be collected, data fields need to be matched up. And your data is only as good as the source that it comes from and how it's collected and maintained, and the age of that data and those kinds of things. The CDL helps with that. Security is another big issue. The amount of information that's being collected can be personal, can be proprietary. I know that there's HIPAA standards out there. And Senate Bill 472, there was a lot of talk of giving access to third parties. Well, if you're going to have third parties, we highly recommend and encourage that the data aggregator have the high trust certification. That security element is really, really important, because the last thing we want is for our patient information to be hacked, stolen, manipulated, used in a way that wasn't contemplated with the APCD. And then lastly, I will just say that, it's not really truly an all-payer claims database. Because the ERISA funds don't have to participate, you're only getting about 70%, as it was testified to in 2019, of the true amount of data. So I don't say that as a criticism, because all of the states are calling it the all-payer claims database. I'm just saying that be mindful as you move forward of the amount of data that you're going to get. And when you get and you organize and you use that information, recognize that it's not a full spectrum of the payer claims, but 2/3 of the claims that are going to be paid. So with that, Mr. Chairman, I will end my comments, and I appreciate all of your time and your hard work during this very interesting and difficult time.
Thank you. Who's next, Sarah?
okay, next we are going to have Mr. Barry Gold.
Thank you. For the record, my name is Barry Gold. I'm the Director of Government Relations for AARP Nevada. AARP is urging the Commission to look at two areas. Two areas really need a lot of things to protect patients here in our state. The first area is the nursing homes. What is happening in nursing homes all across the country is really a crisis in terms of COVID-19 and oversight. and this is going to be lasting for a long time. While Nevada on the surface appears to be doing better than a lot of states, there's still things that need to be look at in terms of testing, PPE, and staffing. Currently, the Nevada State Ombudsman is not allowed to go into the facilities physically, and that creates an obstacle. In some states, while they're not allowing visitation from families, they have made exceptions for the Ombudsman to go in there to make sure things are happening like they're supposed to. So we're hoping that the commission in some way can look at the nursing home situation both now and in the future, because people in nursing homes truly need protection more than a lot of others. They are the most vulnerable among us. And the second area we urge the commission to take a look at moving forward, perhaps with some of your BDRs, is the cost of prescription drugs. Life-saving drugs don't work if you can't afford to take them. So we really need to look at the cost of prescription drugs. That affects everyone in our state. So those are the two areas. So on behalf of the 345,000 AARP members across the state, we're hoping the commission will look at those two areas. Thank you.
Thank you. Next, public comment.
Mr. Chair, it looks like that ends a public comment, but we do have some patient testimony and they are waiting to speak when you're ready.
Right, so that's item number 3 on the agenda, a presentation from patients about their healthcare experiences in Nevada. So could we start with the first one in our list, Sarah?
Yes, that's Miss Donna Yu. I'm going to highlight your video now and you can unmute yourself.
Thank you. Hello, my name is Donna Kelly Yu. I have lived in Nevada since 1992. I'm here today because of my commitment to myself, to my union, to stand strong for all workers together. I've been a Culinary Health Fund participant for almost 22 years. I have many health conditions, including a congenital brain issue, high blood pressure, and diabetes. I have to be very careful with my health and my healthcare providers. I only go to doctors that I trust wholeheartedly. In my 22 years of a Culinary Health Fund participant, I have never had any issues with my data being shared without my permission. I don't even worry about it because of my trust in my union and my trust in my health fund. In the past, I had to transfer my patient history from one doctor to another to take care of my congenital issues. And I've had to sign paperwork to allow that. When I have tests, I get the copies, disc, x-rays in my hand to give to the doctor myself. Regarding our patient medical information, leaders need to think about what can happen to our private information. What will it be used for? How do patients like me get to decide if they want to be a part of it? No one should be able to sell my personal information or use it in any way that I have not agreed to. If it is an opt-out instead of an opt-in, I don't think that we should have that system at all. And I'll tell you why. This year, at the start of the pandemic, my casino job supposedly sent me an email that told us that we must opt out of getting our hard-earned vacation pay paid out instead of going directly to unemployment. Some of my coworkers didn't even receive that email, and some people did not understand the opt-out. I was paid for 2 weeks of my vacation, and it counted as income. That messed up my whole unemployment situation, which caused a big mess. I had to go to the governor's office twice, make thousands of phone calls, write letters to the executives of my company, and go to the HR to fix it. After 11 weeks of no income in the middle of a pandemic, I finally got my first unemployment insurance payment. This is one example of why opt-out is not a good idea. A lot of people don't have computers or emails, and they may not be technology savvy. Opt-out can create a big mess. It will cost money, time, and confusion. Patients should be able to opt into the system instead and sign off with their signature if they want to share their information. Thank you for listening to my story. Thank you.
Thank you. Sarah, who do we have next in line?
Okay, Chair Kahn, let's see. We actually have Mario Sandoval in line. Hold on one moment. Let's see. Ms. Donna, thank you so much. I'm going to remove your screen and put you back as an attendee. Mario Sandoval? Okay. Mario, if you can hear us, you're in the meeting. Okay, Mr. Chair, I'm not sure if it looks like there's a technical difficulty, but we do have one patient testimony. So if we could turn to Leslie, she could read in a patient testimony into the record, and perhaps Mario can figure out his technical difficulties.
Please proceed.
This statement is by Stephanie Schwartz, and she's lived in Nevada for 14 years. During the coronavirus shutdown, I used telemedicine through the Culinary Health Center to receive care. I called in because I thought I had some of the symptoms of COVID-19. I'm a patient at the health center, but because my primary care doctor was not available, I was quickly connected with another doctor. When I spoke to my new doctor, she said I didn't have the symptoms, that she would like me to self-isolate for 7 days. My doctor called me every couple of days to check on me. She even called me to let me know that the CDC had changed its guidelines and that I should be tested. I had already made an appointment with UMC because they had free testing, so I let her know that I was already on the way. I was able to get tested and my results were negative. I did not enjoy my over-the-phone telehealth experience. Some things you have to see to understand. For example, I couldn't show my doctor that I was having breathing problems, and she couldn't tell that I was having breathing issues when I was talking to her. My doctor kept asking me how my tonsils looked, and I didn't know if they looked right or wrong. Sometimes it was difficult to understand her. I think an in-person visit would have been better, and that Skype or Zoom would have been better than my over-the-phone telehealth experience. That said, I hope that Nevada does expand access to telemedicine. As a patient who has to visit the doctor frequently, it is important to me to have telemedicine during the pandemic. I get sore throats a lot and I have vertigo, so it would be nice to be able to always be able to talk to my doctor on the phone or on a video to get medicine instead of having to wait at the doctor's office. I just talk to my doctor, she sends in the prescription to my pharmacy, and I get a text from my pharmacy when it's ready. Lastly, I would like to say that keeping my healthcare information and communications private is very important to me. Through my visits with the Culinary Health Center, my information stays private. I hope that my private information continues to stay private as telehealth access is expanded in our state. If the state would like to share my data, they should have to ask me, and I should have to give consent or opt in. Telemedicine is convenient and it makes it easy for me to get the medicine I need. And I hope that soon everyone in Nevada can have access to telehealth care.
Thank you. We catch up with the other presenter, Sarah?
I believe so. Mario, you're in. It's your time to speak. Okay.
Do you have me? Can you hear
Yes.
me?
Yes, we can. Hi, Mario. Yes, we can hear you.
Okay. First of all, hello and good morning, everyone. My name is Mario Sandoval. I'm a food server at Binion's on Fremont Street in Las Vegas, Nevada. I've been a culinary member for 39 years. Today, I'm here to talk about my health care journey with my Culinary Union Health Fund and insurance, and to share that I would like my data related to my healthcare story to stay private. In 1991, I was diagnosed with brain cancer. Since then, I've been tested every few years to make sure I stay in remission. But now I've been in remission 29 years. I have other health issues now that I need to take medicines. This means that I have 29 years of healthcare data with my doctors that I would like to stay private and only released when I sign off on it. When I have to go see a specialist, there's forms releasing my health information from my primary care doctors. There is a process in place to make sure that my information stays private and is only shared with my approval. I worry if my health care data is handed over to someone else without my permission, they could sell to drug companies who would in turn push more drugs on patients like me who have to take medicines to live. If there's any information exchange, I want to make sure that I sign off on it before it happens. I absolutely do not want any of my patient data to be sold or shared without my approval. I really appreciate how safe my patient data has been with Culinary Health Fund. And I've had my health insurance with them since 1982. I've never received a message that my healthcare data had been breached. I really want to make sure that my health information stays that secure. If the state decides to implement new patient information exchanges and portals. And I want to thank you for your time and sorry for the technical difficulties. Thank you all.
Thank you. Appreciate your input. So moving along, the item number 4 for action, we need a motion to approve the minutes of the last meeting. If there are no suggestions to amend, modify, or change, I would like to entertain a motion. Please identify yourself when you're making the motion and seconding it.
Mason Van Howling to make a motion to approve the last minutes, Mr. Chair.
Second.
Barron for the record, second.
Okay, all those in favor?
Aye.
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 Any opposed? Thank you. So that takes care of the minutes. The next is the item number 5, opening remarks by the chair. I think I've already mentioned that earlier on, and all I would say is please respect time. So we'd like to conclude in the interest of each one of us this time. We are all busy, so we can conclude it on time. So next item 6 is the update on collaboration and coordination between the Commission and other state entities. Sarah has that input.
Great, thank you, Mr. Chair. So Commissioners, I just have a couple of items that I want to bring to your attention. I did send you some emails, but in also wanting to make sure for purposes of public disclosure, wanted the public to also be aware of several other state entities that we are collaborating with. Most notably, the Advisory Committee on Medicaid Innovation I sent over a letter of recommendations on possible subjects for consideration that was approved by that body. And for the members of the public, you will also be able to find this on our website in our meeting materials. What I'd like to do is just make sure that the commission is aware that the advisory committee convened on July 24th, and they approved that letter that I sent around. And I just want to highlight a couple of the focus areas. They indicated their approval for alternative methods of provider and consumer interaction, telehealth, data collection, data sharing, creative partnership and social determinants of health, access to healthcare for young people, often takes place through settings and reaching students who are in virtual school in light of the public health emergency, and they think that that challenge could be a need of attention. In addition to that, learning from disruption associated with COVID-19. So there's a couple of items that are in there. I know you all have had a chance to review it, but again, the purpose of me just bringing it in front of you all is to make sure the public is also aware. If any of you want to connect with me afterwards to further those conversations with any of the members, or have a desire to discuss this with the committee, please let me know. And this is kind of the opportunity to have that discussion. I want to be mindful of the time too, Mr. Chair. So I'll pause and just ask if there's any questions about the committee.
So hearing now, are there any comments? Okay, we'll move to item B and then to C.
Sure. Okay. So item B is the Maternal and Child Health Advisory Board. We have been invited to also collaborate with this board. They're a statutorily governed advisory board, which can make recommendations to the administrator of a division of public and behavioral health, and set a list of kind of maternal and child health topics. The board members indicated that they're interested in a brief update on the activities of the Patient Protection Commission. So I will be going in front of that board later this week, and invited members of this commission to also consider collaborating efforts alongside me. I know that Ms. Yarleni and Ms. Teresa Bohannon both indicated their interest in collaborating with this board. So I will be working with them to discuss collaborative efforts and their participation. They're meeting this Friday at 9 a.m. and they have one more meeting planned this year in November. Again, I will just take a moment to stop and see if anybody has any questions. It looks like Teresa does.
Go ahead, please.
Yeah, I just wanted to briefly say that I looked very quickly, Sarah, at the agenda that the MCHAP is discussing, and it looks like Title V block grant funds might be discussed. And so I would encourage if there is any interest for folks to attend, because that is a pretty big block grant of dollars that come to the state that fund a variety of programs throughout the state.
Thank you. Any other comments from commissioners? If none, then we can move to the next item C. Sarah?
Sure. Okay. So the other item that I wanted to bring up is the Legislative Committee on Healthcare. Most notably, and again, this is, I know I'm repeating myself from our emails, but I want the public to also be aware of our collaborative efforts and their desire to coordinate with this body. Their final meeting is anticipated for this month on August 19th, and we are both up against the same bill draft deadlines. I know that the committee is particularly interested in hearing whether or not this commission has any interest in moving forward with an all-payer claims database. That is something that has been presented in front of their committee, and they are currently deciding whether or not to move forward. So it would be advantageous of our efforts to continue to open that discussion and see if there is any desire on this commission to move forward. And so I can connect back with them and ensure that there is no duplication of efforts in those legislative requests.
Any comments from commissioners? See anybody, Sarah?
I don't.
Okay, so we can move on to the next item. Item number 7. This is for possible action, the discussion of commission work plan and potential bill draft requests. So my comment on this is, thank you for you all who have sent in your recommendations. Obviously, there's a long list of recommendations from all of you, which are all valuable. What I would hope and suggest is that if we can narrow down for our deadline purposes, some of the commonalities in the recommendations so that we can hopefully come to some consensus and incorporate in our bill drafts. And there are a lot of items on the recommendations from various commissioners, as I said, which are all valuable and important. This commission will be in existence for a long time, and we can take them up after this deadline of BDRs has passed and start suggesting some of those recommendations where we either have a consensus or a majority vote to move forward. So the item A is ranked priorities of potential bill draft requests from each commissioner. Sarah, you want to summarize this?
Sure. Let me take a moment to, if it's convenient for everyone, I will share my screen and kind of pull up that working plan. So when we're talking about this discussion, we have a working document in front of me. And also for members of the public, just so you know that this is available on our website. If it isn't already, it's in, the request has been made to have it uploaded so you all can have access to this discussion. So I will pause for just a moment before we go over each one, Chair. And what I'll say is just to let everybody know that the purpose of this exercise was to start the deliberation, the discussion on identifying the recommendations of this body that will fit into 2 different columns. I would say that column 1, which is our potential bill draft request, and this body has the ability to request up to 3. That one is under a tight deadline for September 1. So that means that there's only 2 more meetings that this commission has scheduled in advance of that deadline. And then the second column is identifying recommendations that may not rise to the level of utilizing one of the commission BDRs, but certainly rises to the level of the attention of this commission and will likely be a part of the recommendations of this body to the governor and to the legislature at the end of this year. What I can tell you through this exercise, and commissioners, all of you, thank you so much for making yourself available to me, to discussing and putting in the work of sending in these recommendations. I know you have a lot on your plate, and this was a kind of a large ask, and I really appreciate your immediate attention to this. So in the document, I can tell you that the overall, I would say, commonalities between the commissioners, I could confidently identify, let's start first with COVID-19 management and containment. That item, it seems like the majority of the commission recognizes the efforts around COVID-19 and the pandemic, but also highlighting that as something to be mindful of, but not necessarily rising to the level of utilizing one of the commission's BDRs. And that is really, I think, also, and any of the commissioners can speak in on their opinions too, but also being mindful of the fact that the pandemic is uncertain. So we're kind of in some uncertain times, and knowing that the BDRs are something that will not be discussed until February of next year for discussion through the legislature. I believe it seems like there's more of a desire to shift the focus around long-term recovery solutions versus COVID-19 operations that could potentially be changed and look different in February than they do right now. So that is, I think, the primary focus on recommendations outside of bill draft requests. Now, the commonalities for the bill draft request, I can tell you that it looks like there is a majority for this commission to look into telehealth services. And there's different variables, and that kind of varies amongst the commissioners, and you can see that throughout the document. And then the second item is what you all voted on last meeting, and that is to have a deeper discussion about utilizing a bill draft for transparency measures. And the components also vary, but one of the consistent commonalities is a desire to move forward with an all-payer claims database as one of those components. So that's my summary of what's in the work plan, and I will turn it back over to you on how you want to open up the discussion and where we start.
So thank
or
you.
Have any questions?
So, thank you, Sarah. So the first commonality subject is about COVID, as Sarah mentioned and rightly pointed out. We are not required to have that in the BDR, as the understanding of the governor's request was. I believe he just wanted the commission to be aware of it and be cognizant of it. So if we have any suggestions, recommendations that don't have to necessarily get into a BDR, and as Sarah mentioned, that the BDRs won't be discussed till February, and the dynamics of the COVID situation will change significantly by that time, and the priorities may change. For example, it may be related to the vaccine, the distribution, logistics, etc. So that may change by that time. But certainly I would like to hear from the commissioners any thoughts on that, so that we are not kind of hooked up into the COVID discussion, since it doesn't impact our deadline of BDRs. But please chime in, the commissioners, so we can get your thoughts. Any input from any commissioners?
Yes, so it looks like, hold on one second. We've got Mason Van Houweling.
Thank you, Sarah. Thank you, Mr. Chair. As Sarah mentioned, I think telehealth certainly was accelerated, and particularly during the COVID pandemic, and will continue to be there. And as I've heard from our public comments, really from the beginning, finding that it's been advantageous to be able to connect with their physician without leaving the home and not having to visit a physician's office has been beneficial. I have heard from some of our physician providers that there is an expense around that to be able to deliver that care. And I know at UMC, we've expanded our telemedicine capacity as well through infrastructure and adding more providers. But I certainly think addressing the parity in telemedicine versus an in-person visit is extremely important. Addressing all the networking issues, and I think we've heard from the Hospital Association previously that there has been a major investment in broadband, and just ensuring that connectivity to support telemedicine in rural Nevada is extremely important. So I think that's a common theme that I think we can all agree on, and that we've in particular heard from our patients as much as early as today, that we need to really champion as a body. So I fully support any provisions related around telemedicine that we can strengthen for protection of our patients in Nevada. So I really would like to start the conversation there if we could, Mr. Chair.
Thank you, Mason. Any other commissioners?
I have Jessica Flood.
Just to clarify the request right now, so are we, I thought that we were going to talk about, are we still focusing on COVID or long-term effects and bringing up issues that we might want to discuss around maybe that intersection? Is that right?
So my thought on that is the COVID part is not a part of our deadline for BDRs.
Right. Okay. Yes.
The government is not expecting us to kind of come up with anything specific at this point. He just wanted us to pay attention to that aspect. So my thought is, and you can all chime in, is that since that's not on a deadline, we can give our opinions that are important that will be on the record for future discussion.
Okay, well, so just to throw this out, because I think that there is alignment here with COVID and the BDR, and I'm not sure what that BDR might look like, but rural public health districts, I think, is a very real and pressing issue that has been raised by COVID and would also be a more long-term piece. And Dr. Kahn, maybe we could ask Commissioner Whitley if he could have his staff give an update on what's happening with the rural public health districts, because I remember Julia Peak speaking about it at one point, maybe mentioning that they have a staff member looking into it. But I just don't want that piece of the COVID situation to kind of fall behind the radar as we move into the legislative session.
All right, do we have Richard online?
Yes,
Richard, do you want to comment on that?
sure. I think that the statute lays out, what it takes to become a health district. It does certainly allow for the rurals, but to become a health district, and maybe the timing's right with everything that's going on with COVID-19, that some of the counties would like to have more direct control over public health issues. So I think the authority is there. I think that the engagement and interest, we have like a guide that I could send out that sort of translates the statute into some practical approaches that could be taken locally to become a health district. So I'd be happy to provide that, or anything, anything else. I don't have, unfortunately right now, I don't have the staff, I don't have a dedicated staff person to probably do what's really needed, which is to engage through relationship and then almost like case manage, really, the local, the county, the cities, to configure a district health department. That's really what's needed, I think, ultimately.
So thank you, Richard. Could you please, whatever information you have, just share it with the commissioners for their information?
Absolutely.
All right, thank you. Any other comments from the commissioners?
Yeah, I have Teresa and Bobette also in queue, but can I just back up one moment, Mr. Chair? And one of the things that I also failed to mention that seem to also have a commonality amongst the recommendations is a desire to utilize a BDR for expanded authority of the Patient Protection Commission. Again, there are some variable components to that and differences between some of the commissioners, but really there seemed to be a desire to at least look into that in relation to other boards, oversight, licensures, and then also implementation of some of the transparency measures and components that commissioners have made. So I failed to also include that in my summary.
So my quick comment is that please keep in mind, each BDR is supposed to address one subject. We cannot have 2 or 3 subjects in one BDR. So we need to, obviously, because of that limitation and requirement, focus on a single subject for each BDR recommendation. So continue with the other commissioners' input, please.
Okay, great. Teresa?
I just, Mr. Chairman, kind of back to what Commissioner Flood was discussing. I guess I want a little bit of clarity in the COVID discussion, because I did put a lot of time and effort into putting forth recommendations around COVID because I thought that was our direction. So I'm wondering, do we want to kind of rework those and just sort of present those more as recommendations to the governor and the task force that it will be really probably doing a lot more of this work on a state level?
So a quick response to that is that's a good idea. It's again, to remind ourselves is that we should certainly address that. But if we can narrow down for the deadline with the subjects of importance and then discuss at length the other recommendations related to COVID just after the deadline is passed, and then start really brainstorming the area of COVID that is of interest to everybody. Does that sound fair?
Yeah, absolutely. And I think thinking about beyond COVID, thinking more just along the lines of pandemic preparedness is probably would be a good direction for the commission.
I agree. So who's next in line?
Okay, we have got Babette.
Thank you. Thank you, Mr. Chair and Commission. I want to follow up a little bit on what Commissioner Flood said too regarding COVID. What has been recommended versus what requires statutory change or regulatory change? Because I think one thing we should make sure is none of the COVID recommendations that require statutory change if we're going to start limiting our BDRs. And I would specifically like to hear from Director Whitley and DHHS about whether statutory change is required for utilizing WebIZ to track COVID completely and comprehensively. So I guess what I'm suggesting is, can we take another run at pulling out anything on the recommendations that might be statutory and make sure that nobody feels like we can't recommend those without statutory change before we decide there's going to be no statutory impact?
Thank you, Bob. Did you have a response? Richard, are you on?
Yes, I'm on. I don't believe that the WebIZ requires a statutory change, but you know, one of the things, if I just may, that that seems like a little bit confusing is I think that there's different levels of knowledge about some of these topics that are fairly complex. Health districts, WebIZ, really HIE is very complex. You overlay federal, state, provider needs, patient concerns. I would offer that, like, separate from this meeting, because I think that there's a lot of action that is focused on in this meeting, but I'd be happy to schedule so that if people were interested in an overview of WebIZ, the Health Information Exchange, to be able, and local health departments, districts, to topically maybe go over what is federally, statutorily at a state level required, and what the current status is, because it does seem like I've received lots of emails as well from folks, and it does seem like there's different levels of knowledge, and to just launch in to a topic, it doesn't really make an equal playing field for folks. And so anyway, I would just offer that's separate from this, notice the folks on the meeting and post it and make it available to just do some overview and give the background information on a couple of these topics that are fairly complex.
Thank you, Richard. Any other commissioners have comments?
Dr. Sona?
Yeah, thank you, Sarah, and thank you, Chair Kahn. Just a question for Sarah. I appreciate the rank order prioritization list, and I heard telehealth and transparency, but then I also heard you suggest expanded authority of the PPC. But when I look at when I go through the document, I only see that being raised by two commissioners, Commissioner Rodugan and Commissioner Bond. Can you help me with understanding a little bit better about how the rank orders came about? Because that doesn't seem like it rose to the level of telehealth and transparency, at least by a simple count.
Yeah, sure. And if you want to survey the commission, and all the commissioners can speak up, what I did is that this is just my understanding based on some of the conversations that I've had with some of the commissioners that didn't really capture everything that they wanted on that recommendations. And I know that a lot of commissioners had some hesitations about putting some of their ideas on paper, but that's when I brought up the discussion about expanded authority of the Patient Protection Commission. I noticed that commonality even amongst some of our other meetings, and that was in discussion when this body discussed licensure boards and looking into that. And so I would be remiss if I didn't highlight that, because I just know that there is a desire to at least move forward with the discussion about that in some form. So maybe not at the level of utilizing a BDR, but certainly I think there are a lot of commissioners who have expressed to me that they want to have that a part of the discussion in you know, when you're talking about the BDRs. Another thing is that like Chair Kahn had mentioned with the single subject rule and the document that I sent to you all about the parameters for requesting a bill draft request, we're not sure exactly what all of those components of the bill draft will look like. And so even if you think that one of the items like compliance for one of your recommendations, not sure if that actually requires one bill draft or if it'll require two. So some of the commissioners that I've spoken to just didn't put it a part of their recommendation because they just didn't know, and others felt more comfortable putting it on a piece of paper. So, but if you want to discuss this amongst your fellow commissioners and pull them, by all means, then I think that this is what the opportunity is for. I would just be remiss if I didn't also highlight that, knowing all the conversations that we've had in the meetings that have taken place.
Mr. Chair, just a point of clarification. So I thought that the process we went through was an effort to understand how the commission, every commissioner had an opportunity to submit their priority list. And I thought that this was an opportunity for us to objectively and transparently share our priorities with the commission. Conversations offline, while important, we had a process. And so I want to make sure that we're sticking to the approach that I didn't have any conversation. So if I was supposed to have a conversation, I haven't been invited to have a conversation. And it just seems to me that I thought our approach coming off the last meeting was that we would have a process, we would all openly and transparently share that document as you requested, and then we would prioritize the list based on what people submitted. So I'm confused.
So I would be happy to respond to that. You're right. So based on our discussion in the past, everything that was put in writing was, obviously placed, and that was the process we agreed upon for full transparency of recommendations, suggestions, and thoughts. Sarah, I think, in the abundance of caution on the transparency, brought it up just as an FYI, but we're not necessarily obligated to incorporate in our priorities. It's an FYI. We can still focus on the recommendations that are on paper, like you suggested, and move from there.
Might I request that Sarah, can you please share the top 5 priority ranks for us in order from highest to lowest?
I don't know what you mean by 5 priorities, because they are all in there. When I summarized it, Chair Kahn asked me to think, he thought for the purposes of discussing your commission work plan, that having a summary and at least just kind of a recap of, what I thought was some general commonalities, because, just being mindful of everybody's time and an efficient use of this meeting space, that it would help if I provided this commission with my understanding of the commonalities that I saw within the meeting. So there hasn't been a formal ranking done. And Dr. Slonim, I don't know if you missed my call to have a discussion with me, or you didn't see it on my emails, but I want to make sure that everybody is aware, and so the public is informed too, that the discussions that I've had with each commissioner was an invite that I sent out to all of the commission members, whether you decided to take me up on that offer or not. Some decided to just provide written testimony and send me an email, or others said, I work better by a phone call. And there are many commissioners on here who I spend the time to make it as easy as possible for each one of you to do the work of this commission, and however I can be a resource to you. So those discussions are an open invitation to all of the commission members, and it is embedded in all the emails that I have sent out to this commission. So that's where those discussions took place.
So I have two comments. One,
I would just point out, so it seems as though 6 commissioners have identified, and this makes sense, telehealth, which was the first priority that Sarah raised for us. Transparency was raised by an additional, by 6 commissioners as well. And so from a rank order perspective, which I thought was the purpose of the exercise, although I'm hearing now that that may not have been the purpose of the exercise, I'm just trying to get some clarification, because I thought what we were going to do was submit a document. We went through a lot of trouble to put the document together, and then take the document in total and say what was by consensus the priorities that we were going to further discuss here, so that we didn't have this long laundry list of things. So it seems like there's 2 to 3 things. I could actually go offline and create the frequency list. It's easy to do. Happy to do it.
so I'll just comment on that. You're right. The idea was, and I had suggested to Sarah, just pick up the commonalities. And yes, telehealth and transparency were 2 subjects that had the most commonality from the commissioners. So I think in the interest of time, we can at least focus on those 2. And if a third one props up for a third draft, bill draft, we can certainly go into it. But before we go into the third one, which is not a significant majority's commonality, then we can always go there and see if there's some other commonality. But I think if we focused on these 2, starting telehealth and transparency, then we'll make some progress before we end this meeting, so we have some direction.
Sounds good. Thank you, Mr. Chair.
Sure. Any other comments?
Yes, I have Flo.
Flo, are you on mute?
Can you hear me?
Yes.
Oh, there we go. So Sarah, I just had Dr. Kahn, I just had a question with respect to the all payers claims database. So sorry. I heard that one of the other collaborative bodies that we've been working with, or that we're connected with, is also looking at the all claims payer database. Are they intending to move forward with a bill draft on that? Are you aware of that?
So thanks. You know, I think that it is certainly one of their priorities, and I think that and this is the Legislative Committee on Healthcare. So my understanding is that it is a top priority for them. However, they feel like it fits within the jurisdiction of this commission, and there's a lot of value in having this Patient Protection Commission take a deeper dive, view it, and also move forward with it should this body find value in that. So I can't speak definitively on behalf of the Legislative Committee on Healthcare. I can just tell you that it is a priority to them, and they have expressed their desire to at least get some clarity from the Patient Protection Commission on whether or not this commission will be taking up that discussion. Because if so, then they will likely not move forward in an effort to not duplicate legislative measures. However, I can't speak on certainty with their priorities. I can just tell you that it is one of theirs that they're considering.
So if I may,
Okay,
just
thank you.
on the subject is that we need to, as far as possible, and it has been alluded to by one of the committees, to avoid duplication of the same subjects being addressed by some of the other agencies or committees. So if we can avoid a duplication, that would be ideal, obviously. But if nobody else is addressing that in a serious manner, then it would be obviously helpful for us to certainly look in that.
Understood. I was just wondering if they had a specific proposal that they were looking at on the development of an all claims payer database. But if they're not and they're waiting for us, that's
yeah, and I can actually share with this body or direct you to the Legislative Committee on Healthcare's website. I think I mentioned it at one of our meetings, but I can actually follow up and link the presentations that they received during the interim. And I can also tell you that I think I am aware that maybe several individual legislators are also looking at potential legislative matters. Again, I can't speak on behalf of specific legislators as to what their intent is, but it would be advantageous of this body to decide to either move forward or not move forward, so we could at least extend a reach out to the legislative committee and give them some clarity on what direction this commission would like to take.
So if I may
that.
comment, I think we agreed, and correct me if I'm wrong, that at least we should focus now on the two commonalities, and any other subjects, for example, the claims data, et cetera, we can address that in the third item if that's everybody's consensus, but would be very helpful in the interest of time to get back on those two items and get some discussion going and thoughts on that, so that we can hopefully come to some consensus. What should be our bill draft request on telehealth, and what should be the language for transparency, because transparency is a huge open-ended Pandora's box. So we'll have to spend some time in narrowing down what do we really mean by transparency. So I would suggest if we can get started, if everybody agrees, to focus on these two items, telehealth and the transparency, then I would like to open up the discussion on the telehealth commonality, so that we have everybody's input. What are their thoughts and what do they really mean? If we can focus on what is our understanding individually about the telehealth part, whether it is access, whether it is broadband, whether it is cost factor, whether it is reimbursement, there are various thoughts talked about. So if we can narrow that down in the next hour or so, and then another hour or so for transparency, we will hopefully stay within our deadline of 12 noon, because I'm really very sensitive, to be honest, about the time of every commissioner here, who are all volunteers on this commission. So can we proceed on the telehealth services subject? And I would like to hear from each commissioner before the commissioner has a follow-up question, so that the initial one is one at a time, everybody's input is taken, and then we can go in the second round if there are added comments by the commissioner who has already spoken. So who would like to go? Sarah, you can identify each one of them, please.
Okay, sure. So let's see. Sean, do you want to start?
Sure. Thank you very much. Appreciate it, Mr. Chair. With respect to telehealth, the comments that I would offer there is that some of the commentary so far is making the assumption that payers are not paying the same rate for telehealth services as they are for in-person. I don't believe that any payer has come to this commission and presented and said that they wouldn't. There's been allusions to the fact that they wouldn't, but I don't think that's ever been confirmed. I think that we have to consider that when we suggest what it is we would like for a BDR. Second, and I said it previously when we went through the telehealth discussion, is that we would be legislating what would otherwise be a conversation, a negotiation between two private enterprises. And do we really feel as if that's our place? Third, and if we go back to our first meeting where Governor Sisolak came and spoke to us, he encouraged us to think big. And I don't want us to get so pigeonholed and think so small that we have to legislate what would otherwise be a payment mechanism between two private parties. I think instead you could focus on making the access broader, making the access greater with respect to infrastructure. At the end of the day, anybody who has a smart device or a computer can go on to Teladoc. It's $49 if they really want to. I understand it's not their general primary care physician, but they do have the ability to do that. So I would just caution us to not think so small and finite with respect to the legislating reimbursement between private payers and private physician groups, but instead think larger. Thank you.
Thank you. Any other comments?
Are we just going to go down the list of commissioners? I just don't understand the process.
Yeah, I think everybody, if they could kindly address it, and then we can do beyond that. If one has to talk to another person's opinion, they can address that also. And if you have any questions with the staff, like Richard or others, then we can ask them that same question, as long as we recognize ourselves.
Okay, let's move on to Teresa.
Yeah, thank you, Sarah and Chairman. I I just want to go back to something that was said in the last commission meeting, which I believe was by Dr. Barron, and to continuously ground ourselves in how does this benefit patients, and to really move away from how this benefits the industry. You know, a lot of discussion about payer and this and that. Like, I really want us to think about how are we going to ease access for patients. There's a lot of uninsured people out there that probably don't have access to telehealth, or, you know, they would have to kind of search through these various mechanisms or private companies that are out there. So I just want us to always come back to the question of how this is going to benefit a patient that's out there. And that's really just my comment.
Thank you. Who else do we have?
Jessica?
Yeah, I think that there's been a lot of discussion nationally and in this state that the expansion that has occurred from the response to COVID has been really beneficial for telehealth. It's kind of pushed it forward. So I know that the Southern Regional, or the Clark County Regional Behavioral Health Policy Board, wanted to look at continued expansion of telehealth for behavioral health. But it would be worth it to look at continued expansion at the levels it is that the governor's put forward past the crisis time. The other one is looking at parity for telehealth versus inpatient visits. And to Commissioner Sean, I don't know your last name, I'm sorry, Schoner's point, I don't know if it has to get really specific in really mandating those pieces, but just really looking at that parity piece. And finally, really also looking at expansion of originating sites. So if patients are using telehealth at home, ensuring that there's a way that there's reimbursement for that. So those are the three things that I'd like to look at for this telehealth piece.
Thank you. Who's next, Sarah?
Flo?
Thank you, Sarah and Dr. Kahn. So I just wanted to say that I agree with, in reviewing the work plan, I thought that Mason had summed up very nicely the telehealth provisions that would need to be included in a BDR potentially, particularly with the codifying the current COVID-19 related telehealth or telemedicine procedures or provisions. We heard a lot about that in our telehealth presentation. And I thought there were some really good components there that we could very easily get into state statute and codify and move forward on. I also agree with Sean's perspective about not getting too specific. As he said, there are insurers who are already providing parity for telehealth, and that should be something that maybe we can review, but definitely we shouldn't be mandating in statute. That's, again, my perspective on that. But there were also some licensure issues that seemed pretty quick that we could have a direct access, and going to Teresa's point of view, that would, would have a direct impact for patients by making sure we had more specialists available to the consumer. I think is very important. And so to the extent we can do that. And finally, the IT provisions, that is one area where I think there's a lot of struggle making sure that we have IT interoperability is going to be incredibly important.
Thank you. Who's next in line, Sarah?
Jessica, did you need to circle back?
Oh, sorry, I'll lower my hand. But if I could just throw it out, I agree exactly with what Flo said, is I could just copy and paste Mason's points on telehealth.
Thank you.
Okay, I don't see any, oh, Bobette? You're on mute.
Sorry, thank you. Thank you, Sarah, and thank you, Chairman. I'm mixed on this. I feel like whatever we can be doing to push interoperability inside every physician's office and every hospital is critical. And I think that that is what CMS and ONC are now requiring us to do. And I think that that carries over into patient access to that information. So I'm totally comfortable with telehealth BDR that focuses on telehealth access, and how do we help the doctors become telehealth competent, and how do we help patients have access, as Jessica was saying, that third issue of patients need to get in as easily as doctors need to get out. What can we do? But when you get to parity, payment parity, I have mixed views. I feel like primary care doctors and behavioral health doctors for sure have to have, it's critical that they be able to reach patients and patients be able to reach them, just because of the volume of access needed, the continuity in mental health and primary care that is needed to prevent more expensive issues from happening. I think that, so I don't know if we can bifurcate the notion of parity in payment, but I really support the interoperability. Just my thought on this.
Thanks, Babette. And next in line for comments.
I'm going to just pause it. We've got Commissioner Richardson, our ex officio.
Hi, good morning, everybody. So I wanted to let folks know in general that Nevada actually has anywhere between 8 to 11% of citizens who are uninsured in some way, shape, or form, and that number varies every year depending on what's going on with the economy. But some of those uninsured actually have access to a type of coverage. It's just not considered insurance under the regulatory world. So that is a fairly small amount. So focusing on the uninsured probably is not going to be as helpful as focusing on the insured, especially for this particular commission. The other thing I wanted to bring up is that statutorily in the admitted market, telehealth is to be a, and I understand that folks don't feel comfortable talking about parity for payments, but I will tell you, if you don't put parity in payments in the statute, you will not get parity in payments from the insurance carriers. It just will not happen. Negotiations are not. And they might not like it, but they also, sometimes have to have specific guidelines to help them out. The couple things that you need to be thinking about, which have already been brought up, is expanded broadband, no restrictions by licensing boards on doing telehealth, and to make sure that that behavioral health is noted, because there is a mental health parity law on the federal books that would then support that being embraced on a state level. And then the only other thing that folks should know in general that I think is important is one of the groups that seems to feel uncomfortable is not just the licensing board, but the hospitals themselves or folks who might feel like the providers from out of state might be taking in-state services away from them. So keep that in mind as you're trying to, wordsmith your CDR.
All right. Thank you, Sarah. Who else is online?
We've got Dr. Barron.
Yeah, I appreciate the comments that everybody else has made regarding telehealth and parity. To Commissioner Shaner's point about parity or mandating parity in statute, keep in mind that that is not the same thing as negotiating rates between two private entities. Those negotiations continue to be what they are. And what the proposal says is that whatever the rates are that have been previously negotiated between the two parties, that for a similar level of service on telehealth, that the same rate would be paid. So there's really no taking away of the negotiations between the two entities in doing this. As a person with boots on the ground who quickly had to adapt to a large majority of our subspecialty pediatric patients receiving telehealth in March and April and through May, it was feasible largely because there was a cost associated with it to providers to purchase the platform and enact it. And there's also a time commitment to perform telehealth that is similar, if not greater, to in-person visits. As I think I mentioned on a previous commission call, in a normal operating medical office, the physician or practitioner can be seeing a patient while one is checking in and the third is checking out. Whereas in telehealth, everything happens in series. And so the ability to somehow increase volume of patients being seen in a given clinic or given time simply by having a telehealth platform isn't really there. So we're not talking about a sudden swarm of additional volume of patients that the payers have to pay for simply by giving them this one additional access point. And to Teresa's point, this is all about patient access. There is no increase in pay for providers, hospitals, et cetera, that provide this platform. We're just talking about parity in pay, and which I think can go a long way to increasing the capability of patients to get in, especially in hard to reach places such as rural and at-risk counties. So I would propose that we do include, as Commissioner Richardson or Director Richardson said, if you don't put something in statute about payment parity, it will not happen. And I can tell you as a provider that has to bill for services that it is not in parity, other than the fact that the feds are mandating it right now under the COVID emergency guidelines. When that goes away, we'll be back to where we were before. So I would heartily include the idea of parity in a BDR that talks about telehealth and access.
Thank you.
Okay, Dr. Flonam.
Thank you, Sarah and Commissioner Kahn. Just a couple of quick comments. I think that I would echo the comments about parity. I think necessity, and we saw during COVID that parity did occur, and at a national level improved access, which is what this is all about. Again, acknowledge the contributions by Commissioner Van Helling. I think that was very well written, and just want to put a focus on the other piece of this, which is licensure boards and how they have to help us make sure that we're getting reciprocity to improve the access issue, which is very, very important. So thank you for that.
Thank you, Tony. We have next in line.
Okay, Babette.
I've already spoken once on this, so I can wait. I mostly just wanted to ask Commissioner Richardson what data she's using to say that that parity doesn't exist if you don't put it in a contract, or if you don't put it in statute. I'm sorry. You're saying that if there's no statute of parity that it won't happen, and I'm assuming there's data for that because of the way you're saying it. So I'd love to understand where that database is.
So this is Commissioner Richardson. So I don't have data specifically on saying parity won't happen because it's not required now. But in general, working with insurance carriers, there is no reason for them to do any kind of contracted parity unless we require them to.
Mr. Chair, do you mind if I follow up?
Yeah, go ahead.
Thank you. I feel like this whole conversation about the need for parity to allow access is sort of like kind of in conflict with what you're saying right now. I think insurance companies are finding that they need to pay. They need to pay to make sure that patients have access. So I would love to see data, and I guess thanks.
All right, thank you. Who's next in line, Sarah?
Okay, if we can, you want me to highlight some of the commissioners that have not spoken yet? I know that there's hands being raised if commissioners have already spoken, so just to be mindful to hear from everyone. Yarleni?
Yeah, I would really want to hear from everybody if you can identify who we have not heard from.
Sure, Yarleni?
Yes, so I agree with Mason about his bill draft request for telehealth. I think that addressing the licensure, we heard somebody did a presentation on how we can do licensing compacts. And I would like to know if maybe that could be a way that we can make it easier for more doctors to come to and practice in Nevada. And I think that's my only thing that may be added into Mason's bill request.
Thank you. Sarah, who's next in
Okay,
line?
Dr. Packham?
I honestly agree with everything I've heard so far, particularly the detail that Mason provided. So,
All right, thank you. John, who's next?
Okay, looks like we need to hear from Mason himself.
Well, I think I've said kind of early on in the introduction and the question, so I'm good, Mr. Chair.
Thanks, Mason. Who else has not spoken, Sarah?
I don't believe, I think we've heard from everyone. Let me just make sure, is there anybody that we haven't heard from? By my count, I think we've heard from all of the commissioners.
So I think we can go a second round that commissioners may have, all those who have spoken, any additional comments or observations or questions of anybody. So we can at least narrow things down and then see if there is consensus or a majority vote on the subjects.
So Mr. Chair, if I may, can I offer to pull up my shared screen so that way we can actually look at Mason's proposals? It seems like there's an appetite to look at what he recommended and then maybe starting to narrow down there. So if it's beneficial for this commission, I will share my screen, and as you are continuing this deliberation, I can make changes and then anticipation for potential action on this.
I think the recommendation specific to telehealth, because that's our subject.
Right, right. And I will just share that portion of Mason's recommendation only. Is that helpful? Okay.
Yeah, that's fine. So if we'd love to go through with the second round of questions or comments on so far, everybody has heard everybody's opinion in the initial go around. We can take a second go around, and please identify yourself so that we get everybody included for a second view, a second opinion. Sarah, could you kindly identify?
Yep, absolutely. I think let's start with Yarleni.
Yes, so now that we're looking at the actual bill draft that Mason wrote, I was thinking that maybe could we start editing the bill draft as we speak? Because this is the first time I'm doing something like this, so I don't know exactly how it works, the actual writing of it. Could we work on that right now as a group?
Yes, unless our dad tells me otherwise. I thought that this would be a really beneficial way for everyone to make sure that there's clarity in your discussions and your votes and you know, kind of narrowing it down. So as you are all deliberating and before you proceed to even think about an action, I would, you know, start taking notes as you're deliberating. But I will defer to our DAG on making sure that this is okay.
Deputy Attorney General Greg, there's no problem with that. You can workshop the language in this manner to as much as you need.
Thank you. So if that's beneficial to everybody, then I'll keep this screen up and then let you all continue your deliberations.
So any second comments and thoughts from commissioners that have given our first line of thoughts?
Okay, so it looks like I've got Yarleni. Did you want to continue your discussion or move on to the next person who has their hand raised?
Yes, this is Yarleni. I would like to see, since we could edit the document as we speak, how would we add where it says, I think that it needs to be more specific on the 1, 2, 3, 4 points that Mason added on it. How could we be more specific on addressing licensure and adequacy of network issues to include the compact, licensure compact, it's there. And addressing the parity for payment. Do we need to be more specific, or is that good enough since we have been speaking about the parity between insurance payment for people with insurance and non-insured patients?
So if I may, the licensure part, obviously, since we can include only one subject per bill draft. So I think in the first item we are discussing, we would obviously ideally want to focus on all the issues related to telehealth that are being brought up. And then certainly in item number 2 or 3, discuss the other subjects that we want to address. So, okay, who's next in line?
Sarah.
Yeah, it looks like I have Dr. Barron.
Can I just say one thing, just in response to Chair Kahn? I just have one thing. So usually for a bill draft, you can have a pretty broad bill draft and then cover all of these subsections under it. So I just want to make sure we're all on the same page with that. I don't know if we need to cut this down, as long as the topic relates to all of them. So I just wanted to see.
If I can, Chair Kahn, maybe I can actually expand on that, because I think that's a really good thing to highlight, Jessica. And I think that, you know, speaking to the Legislative Council Bureau, I think it's to be mindful of the single subject rule and to be as detailed as possible. But I think, you know, for purposes of your deliberation and moving forward with action, you can certainly submit or move forward with this outline and have broader terms than just having a general direction. Allows me the opportunity to then go and seek additional guidance from legal and legislative counsel. So then what I could do is, given that direction, I could then work to get language and other you know, specifics on requirements for bill draft. And then basically I would lean on our DAG and the Legislative Council Bureau for kind of fine tuning some of these. But I think for purposes of this discussion, your work, keeping it at this level broadly is sufficient. But I mean, broadly, but also specific, right? I think the way Mason has it outlined is sufficient for this first step. Does that make sense, Jessica?
Right, yeah, so
Yeah.
just like to say, yeah, exactly, that, you know, if we said increase access to telehealth. Sorry, I can't hear, there's like a, okay. So yeah, increase access to telehealth, all these things increase access to telehealth. So potentially we don't have to vote on one of these things. All of these could be one big bill. So I'm just hoping we can see that instead of like paring it down.
All right, thank you. Who's next?
Dr. Barron?
Yeah, so for example, under sub item number 1, codify current COVID-19 related telemedicine provisions, I would maybe modify that, say current emergency COVID-19 related telemedicine provisions. And if you do that, then you actually have included item subsection number 3 in that, because that addresses the parity for payment. It may be worthwhile for the commission to have a copy of the specifics of the emergency COVID-19 related telemedicine provisions, because there may be some things in there that people don't want to codify. For example, there's some HIPAA waiver issues in that, so that people could do non-HIPAA secured FaceTime calls with their patients and so forth. And I don't know going forward whether there's a taste for the commission to want to continue some of those things or not. So the point being is that if we codify the current emergency COVID-19 related telemedicine provisions, it includes the parity for payment, which maybe there's a taste to do, but maybe there's other things in there like the HIPAA waivers and so forth that there isn't a taste to do. And so I just want to be mindful of the fact that that's a large number of different things that were codified by the feds. And I would like to see some of them certainly continue as a state statute beyond the point of emergency declaration.
Thank you, Dr. Barron. Who's next that hasn't spoken yet?
Mason?
Thank you, Sarah. Thank you, Mr. Chair. I just kind of reviewing everybody's comments around telehealth, and I don't want to miss an opportunity to incorporate mental health. I don't know if we need to clarify that in the language, since we are trying to address that in many of our discussions. And then just seeing some of the common things, like Dr. Sloanum's got the licensing, reciprocity, sorry guys, reciprocal licensing through other states, which is part of that emergency order that Dr. Barron was talking about. So maybe talking about that, and the providers are far more educated on the licensing part than I am, but is there a way to incorporate the licensing compact and then also calling out mental health as well as part of telemedicine? I just see that as a common theme.
Yeah, so Mason, if I may, on this licensing issue, again, it has to be one subject per bill draft, but having said that, if this licensing part is required in the long term for statutory issues, then it's one sub area. And the other one is the reciprocity only during the emergency. Now, I believe the governor had already allowed physicians from other states when this all started to be able to have an expedited process to get in to take care of people if they have to, if there's a shortage of providers. So we need to focus somehow where we're not doubling the subject in one bill draft, although the licensing part is also pretty crucial, like a lot of you have alluded to.
Thanks, Dr. Kahn.
Who's next, Sarah?
Flo?
Yes, so thank you. All I was gonna add is I think this is wonderful. I would agree with Dr. Barron that it would be helpful to have in writing kind of all of the provisions that we would want to see included. So if there's a way based on this, and I guess my initial question was, does Ledge Council believe that what we're providing just generally, these broad topics, that they would be able to go back and draft something then that we could review and go through, at least to know which provisions we kind of agree with, what we might have concerns with, so that we have something in front of us that we can work off of, would be, in my opinion, would be helpful.
So that is very helpful suggestion. The only question I would have on that is that given the time constraints, if we come to some consensus on a couple of bill drafts, and at least we can have them some language, I'm not sure whether logistically it's possible, draft by next meeting, so we can narrow things down and get it behind us for some action forward. Sarah, the Attorney General's office, may be able to answer whether it's feasible.
Sure. So what I can say is that we are required, and if you all want to pull up the document that I sent you, that the LCB sent this commission, kind of outlining some guidelines for bill draft requests. So it's pretty specific, but it's also, there's a lot of room for interpretation. So in general, we need to be as specific as possible to request a bill draft, and it has to be submitted on a form that's given to us. They have not yet produced that form. There is a sample of the ones that they've requested for similar bodies in the prior session, so that you can just understand the parameters that we have. However, I think being as very specific as you can is what I think the goal is, just like either deciding to use language like emergency COVID-19, I would actually lean towards making sure that if you want to include parity for payment in part of your recommendations, that you actually list it here as a part of the full recommendation. So be as specific as you can, and then we'll narrow down the language as we move forward. And whatever you decide to do, even at this stage, you can certainly reverse it at another meeting as it's progressing, and then having opportunities to see this language, essentially, my words, mature. So, having some clarity now and then just adapting at each meeting, and then just having the different phases, I think is helpful. And one more thing, Chair, is that outside of the bill draft deadline, there is another deadline for pre-filing. So in between the pre-filing deadline and after our bill draft request is time to where we really will start narrowing down some of that actual language, getting back from and working with the Legislative Counsel Bureau. Prior to that, it's really our work.
So, which is helpful. So my request would be if we can start, once everybody's heard, narrowing down to some close to specifics so that we have some basis to fine tune those specifics in a timely manner. So who has not spoken yet, Sarah?
Flo?
Sarah, I just spoke.
Okay, let me lower your hand. So
I
sorry.
have to take my
That's
headphones out.
okay.
Sorry.
That's okay. Sean?
Thank you, Sarah. Thank you, Mr. Chair. I just would echo what the other two commissioners said. I think that as we sit here right now, I don't know every emergency COVID-related telemedicine provision. Dr. Barron raises a good example of something that we might not feel comfortable with respect to allowing and codifying an NRS that providers be allowed to do telemedicine over FaceTime forever following this, because if I heard him correctly, I think that's one of the provisions. I don't know what the others are. I'm going to look them up right now, but I think it would be prudent of us before we, I don't know, Mr. Chair, if your intent is to take a vote, but before we all vote on this, to know exactly what those provisions are and understand what they are prior to moving forward. So I appreciate the time.
Thanks, Sean. Who else has not spoken yet?
It looks like Teresa.
Yeah, thank you. I just, Chairman, I wanted to just bring to the attention of the commission that there's 3 other states that have just recently passed this type of legislation. And I think it would be advantageous for us to kind of look to see what they've done. And one of the things that's happening in Connecticut, which I'd like to suggest that we think about, is expanding the list of providers that can use telehealth. They included art and music therapists, athletic trainers, behavioral analysts, dentists, et cetera, et cetera. So I think also New Hampshire and Colorado have worked on this as well. So I think it would be in our benefit. And then also making sure to follow what's happening at the national level, just to make sure that we're kind of in line with everything that's happening around telehealth.
Thank you. Anybody else left, Sarah?
Yeah, there's several, but if I could take a moment, Mr. Chair, and let you know, I have been listening to some of the deliberations, and by my count, it looks like, in particular, with this addressing parity for payment, it looks like it's a deadlock with this commission. So I don't know how you want to proceed with telehealth, but it looks like by my count, it's 5 for it and 5 against it. If there is a need to kind of narrow that down or consider that one entirely, I just at least wanted to throw it out there that that one seems to be the one that is the item that you all are struggling with as a commission.
No, which is fine. After everybody has spoken, what
Okay.
my hope is to put this recommendation from Mason. I guess it'll have to be individual items, and then just take a vote and see on the parity, since that's the one that people have a difference of opinion. So we'll narrow it down to a vote after we have listened to everybody.
Okay,
Go one item at a time, depending on how everybody feels.
Great. So it looks like everybody wants to speak again. So I'm just going to start with Jessica, if that's okay. But it looks like I've got 5 commissioners who have spoken but want to speak again.
Okay.
First one being Jessica.
Thank you. So in response to parity, I mean, I get the sense that people aren't totally against it. They just want to make sure, there's several commissioners that want to make sure it's not too specific and really gets in the way of contracts, which makes a lot of sense. The Nevada Psychiatric Association actually had a really nice handout on parity recently, and they brought up that the feds have a parity law, which kind of shows the need for why you have to put parity into law. But Nevada has a complaint-driven regulatory model, which creates a huge process. So basically, you have to identify there's an issue with parity, then you have to bring it up to the regulatory oversight, and then it goes through this whole process. And they recommend that you can ask for proactive documentation on how you are meeting parity. And that could be a win-win, so that providers can say, yes, look, these are our parity laws and this is how we're doing it. And it's not that real specific. So I wanted to bring up really a more specific way of addressing parity for payment, because I think that can be pretty scary. Also around telehealth, I just wanted to add potentially to ensure that there's sufficient access to technology and connectivity to support telemedicine in rural Nevada, considering broadband access, because I think that there's a real issue with broadband. And then, like I was saying, that originating sites, making sure that we're expanding originating sites to allow for flexibility in the system. And I think that might be all I have.
So in response to your comment, if I may try to clarify, as I have understood during our past deliberations, the question of parity is not related to contracting rates. It was discussed before. It is related to the fact that if a patient under the circumstances is using telemedicine for access instead of coming in person, so whatever the rate or contracted rate is for an in-person visit, it's the same payment that is provided for the telehealth access to that provider. It does not require anything to do with contracting rates or how much the rate is. It's just that reimbursement for telemedicine, since the majority are using it, and Dr. Barron has alluded to last time and this time that in some cases it may cost more, but even if it doesn't cost more, the question is it should be reimbursed equal to an in-office visit, so that the physicians, the primary care physicians, are not discouraged from seeing patients on telehealth because the reimbursement in telehealth will be lower than in-person visits. So it's not about contracts or rates negotiated. It's existing rates. It's just that to pay it just like an in-person visit. So having said that, who else is in line?
Sean?
I already spoke.
Okay.
Sorry.
Okay, great. Teresa?
I've already spoken.
Okay.
I don't see though under mental health, like I would like to see an expansion of the type of services that are offered through telehealth, because I want to point out to the commission that Clark County and some other schools, a lot of parents are going to be choosing distance learning for their children, and I think that there's going to be some significant behavioral issues. And so we want to be conscientious of maybe some of those services can be used through telehealth, since they won't be able to access it in the school setting.
All right, who's next?
Bobette?
Thank you, Sarah. Thank you, commissioners. I think under subpoint I, codify the COVID-related telemedicine provisions. I think that Dr. Bannon said something really important there. Dr. Bannon, sorry. I think that the way that it's split in the law, in the relaxation of the HIPAA rules, is there's a way for patients, they're no longer able to prevent their information from being transmitted because of the emergency. So I do think we need to be very, very careful about codifying that. I wouldn't support that, but relaxing the venues, relaxing being able to do it on Skype or telephone or, Facebook, that is what I think has been a critical game changer for us in terms of our members' access. So I really want to make sure we try to do that. I think we'll need the DAG to help us understand what we can do about that with federal rules. So I'd just like to push those apart a little bit, because one of them is really important to protect and the other one's really important to try to, continue to do. And then on the very end, where you're talking about Jessica's point about what does she call it? What's the very last bullet there? Originating site. Yeah, I think we need to make sure we're making it clear that the patient call into their care provider, whether, maybe there's a way to protect that access where they can call in with whatever vehicle they want, even if the doctor can't call out. We gotta figure out how to have patients have better access there. And patients of all stripes, right? We're talking about the rurals, but you've got seniors, you've got a lot of people that are low income, that really challenges that we should try to be careful of in the statute.
Thanks, Bobette. Who else is in line?
Commissioner Richardson?
So yeah, I actually want to follow up on one of the points that Commissioner Bond put forward, specifically having to do with protections on the different types of technology that can be used. You might want to consider putting in here the ability to have regulations put forward for especially those kind of HIPAA protections. Because if you get too specific in this statute, you may not be able to keep up with the technology. So the protections are really important. It's just that, like I said, that, you know, the minute you put one into statute, it's going to be rough to try to keep up with everything that's going on. But they are really important to put in place.
Okay, Dr. Barron.
So I was going to comment on the licensure compact portion under number 3. So more specifically, for example, I believe that the Nevada Board of Medical Examiners already participates in the existing licensure interstate compact, which I think about 16 states participate in. So what we might want to flesh out in that item is specifically all licensing boards, should be required to participate in interstate compacts where they exist. So for example, I remember in one of our meetings, a nice chart that somebody presented as to what the current state of affairs is with the nursing board, board of pharmacy, board of medical examiners, osteopathic board, etc. And it would be nice to ask all practitioners that have to be licensed within our state to be able to use an interstate licensure compact where it exists. So I didn't want this to be exclusionary from any other professionals that provide medical care in our state, and so it seems like, and we may already be meeting that mark with the Board of Medical Examiners for the MDs anyway. So I just wanted to make sure that it was expanded to all practitioners.
Thank you. I think we'll take the other comment. We need to move on to the vote or consensus, either or, so that we have some time left for the other subject.
Great. It looks like, Teresa? And then Director, if you don't mind, Teresa, Director Whitley, I think, wants to speak up.
Yeah.
Hi, this is Richard. I just wanted to mention 2 things. One is on the pay parity. Medicaid does have pay parity. It's not required by CMS, but Nevada opted to have pay parity. So just wanted to give an example of where it's not statutorily required. And in fact, we see the value in it and didn't go there as a cost reduction strategy most recently. I also would like to comment that I think that there needs to be mention of health literacy related to the consumer and ensuring that the service is appropriate to the patient. And I think that it does fall under health literacy. I don't have the formation of the policy. I think the licensing boards do touch on, I think, what's covered in terms of a service under their authority. But I think as we create this framework, we certainly have a concern in Medicaid with that, it can be a vehicle for maybe abuse or inappropriate use because of convenience. So it's just important to me that we mention, because we serve in Medicaid a population that is mostly does experience disparity with poverty, certainly, but with other determinants of health that those considerations, be put in place as well. So anyway, I just wanted to mention that I think health literacy is an assessment of the capacity of the consumer.
Thank you, Richard. We have the next commissioner.
Yep, Teresa.
Yeah, and just thank you, Richard, for that. I think along the lines of literacy, we have to be cognizant of language barriers. We can't just be providing all these services in English and expecting that there be equal access to the services. So I think I'm wondering just kind of broadly, as looking at some of the other states, of thinking about including some sort of formal study of how these services are delivered, and that ensuring that there's equal access among all populations. So as we push these services forward, that we're also ensuring that people are getting the type of care that they need, and that all of this is all the type of care that is being provided, that it's patient-centered.
Thank you. Who else is there?
Dr. Packham?
Yeah, and just to echo Teresa's comments, maybe just as we have health literacy for patients, we have cultural competency for providers.
Thank you. Anyone left out still? Okay.
Yarleni?
Yes. So I was wondering if there's any way, since we're talking about making sure that there is health literacy for patients and cultural competency for providers and a study on equal access, could we add that there would be a review of how the telehealth is working across Nevada once if the bill is approved, to make sure that it is meeting the requirements and the necessities of the community?
Thank you, Lenny. Is there anybody else so that we can narrow down to our decision to decide on the vote? All right. So if hearing none, so if I may summarize, besides other areas of original Mason's recommendation, we're talking about the parity is the one that is of concern to several of us one way or the other. So having said that, perhaps if it's okay with everybody, and even in parity, now there are two thoughts of it brought in originally by Dr. Barron about whether it should be applied to the emergency COVID for a period of time and not in perpetuity. So what I would suggest is we can just take a vote on parity on payment, which, as I said earlier, has nothing to do with what the contracted rates are and that is certainly a proprietary information. And I'm certainly not for that personally either. So if we can take a vote on that, but before we go on to that, we need to decide whether we want to have it a vote on an emergency, subject of emergency authorization or in perpetuity. So that is my thought on this subject. So on clarity on the emergency thing, probably it's more technical. Richard, would you like to elaborate so everybody understands what would be the difference putting in the word emergency or otherwise? Richard, are you there?
Yes, I'm here. I guess point of what I just need a clarification in terms of my understanding was that it was to capture what is currently being provided under emergency provisions, but maybe I misunderstood.
So the originally subject was parity in telemedicine payment, basically, which was like same as an office visit payment, is my understanding of that. Whether it should, the added word should be for emergency, as Dr. Barron and I think Sean Schooner had suggested, because the word emergency was not in the original Mason's recommendation.
Mr. Chairman, Howard Barron for the record. I just wanted to clarify that when item number 1 was originally brought forth by Mason, it said, codify current COVID-19 related telemedicine provisions. I just wanted to add the term emergency to COVID-19 because it would be all inclusive of all the emergency provisions that were brought forth by CMS. And then I went on to say that some of those emergency provisions, like some of the HIPAA waivers and things like that, might not be to the commission's liking, and we may want to look at those individually to see which of the emergency provisions we want to continue in state statute as opposed to letting them expire when the emergency provision expires. So I just wanted to be clear. Director Whitley was absolutely correct when he was summarizing my thoughts.
So is that summary sounds reasonable to everybody?
Yes.
So I
Sean
think
has his hand. Well, Mr. Chair, sorry, Sean Chainer.
Yeah.
Yeah, Mr. Chair, thank you, sir. I just have one question with respect to the emergency provisions, and maybe Dr. Barron knows best. I'm sorry to put him on the spot, but I believe that one of the emergency provisions is that a physician is allowed to have an audio phone call with a patient and then in turn bill that as they would an in-person office visit. Am I correct in that assumption? Dr. Barron, do you know?
That's correct. And for example, that might be one of the emergency provisions that we don't want to codify, you know, just as an example.
Right. So I throw that out there simply to show an example of something that if you codify that in NRS, it is there forever until it's taken out. And a simple phone call, should that be reimbursed at the same level as an in-person office visit? And I just want us to be aware of an example that we might not necessarily all agree on.
So Sean, to your point, we are obviously focusing on telemedicine visit. If it is specifically telemedicine visit, then phone call is not a part of that. It's the way I understand that. Unless
but it is a part of the emergency. He's right. It is part of the emergency declaration. Yeah.
So then we may want to, in the language, exclude the telephone call part of it, if that makes more sense. So could you give us a general draft part of it, Sarah, as to one item on parity, how would that look like in language without phone call part of it?
Yeah, the way I have it outlined here, I think, is just trying to capture at a high level what everybody's intent is. I think the overall goal is to codify current COVID-19 related telemedicine provisions, and then more specifically to make sure that that does address parity for payment. And then the further discussion is whether or not that captures emergency provisions. And then a part of that, as Sean mentioned, excluding phone call service. So the way I have it is, I think, captures everybody's comments on this portion.
Yeah. Anybody has comment on the basic understanding so far for a vote?
And Mr. Chair, what I can also tell the commissioners is, given this, what I could do is, this is enough direction to then try to create better language for further deliberation at the next meeting, but at least getting some clarity on whether or not the commission feels okay moving forward with these provisions.
Yeah, absolutely. At least if we agree in generality of the basic understanding of everybody by consensus or vote either or, this will be fine-tuned more than once because the BDR people will also fine-tune the language before it gets to the final version. That's why when there's a draft BDR, we will have to look at it in a deadline basis to come up with the final fine-tuning on that. So if I may request that on the understanding that was displayed by Sarah as the understanding, and that does include the emergency part in the third line, I believe. So we can at least take a vote or a consensus, whatever it is. Either way is fine with me. We can certainly take a vote. Those in favor of this outline.
Sure. Flo and Bobette both would like to speak.
Okay.
Flo?
Thank you. So yes, I guess that just kind of made it clear in terms of we're going to be voting to allow for the drafting of a provision or the telehealth, the codifying of the current emergency COVID-related telemedicine provisions, knowing that at some point we're going to come back and be able to, we'll have time to review those provisions, and then we can go in and discuss areas where we would have concerns, because we haven't seen all of them, at least right now, and not knowing exactly what's in there. But this is just going to be a vote to allow the Ledge Council to draft something, and then we'll have time at the next meeting, after we've had time to review it, then to come back and make changes or request changes, correct?
So, Babette, so your understanding is if the word emergency and related parity to COVID right now, rather than an open-ended one like several have alluded to.
So I think, go ahead.
Mr. Chair, if I may, I think, Flo, I think if I can summarize and I think provide some clarity, I believe what you're asking is just the process in like the next steps and what you're voting on. At least my understanding is this is a discussion and potential action item for you all to consider moving forward with further deliberation at our next meeting. So this is enough provisions for me to utilize some resources, LCB and legal and legislative counsel to kind of start to narrow down more language, capturing these items, and then again, having this up for further deliberation at your next meeting in advance of submitting a bill draft request by September 1.
Thank you. Is there some other comment from somebody was left?
Babette.
Yes, Babette.
Thank you, Mr. Chair. I think this first section still needs work before it leaves us. I think these emergency provisions that Dr. Barron first talked about include people's ability to keep their COVID information private are being waived. I think that's what we don't want to have continue after the emergency is over. I think that's what we should exclude. I don't think we should exclude phone calls from telehealth in the future. I think they've provided a huge resource for people, for patients particularly, and for doctors that don't have an expensive telehealth system, because people can just talk to their doctor. If that reverts back to the original HIPAA rules, the real HIPAA rules, that's no longer allowed. And I think that that's a really important provision to keep. So I don't want to vote on excluding call service. I understand that you're attaching it to payment parity for that. I don't want those coupled. I want to make sure that whatever comes out of Nevada statute, doctors can still talk to patients on the phone, and that's considered telehealth access, so that HIPAA doesn't stop that from happening.
So, Babette, you bring up a good point. So, as I have understood from the discussion so far, it's the parity for payment is the primary issue, and the question was the payment parity, not take away the phone call option, certainly not, and that you bring up a strong point there. But the payment for the phone call cannot be at parity for a telemedicine payment. It's a question, obviously it's a different payment, whatever the contracts people have negotiated. So it's all about parity. If we lump phone call as parity with telemedicine as an in-person visit, that would not be fair to the payer either, to include that in parity of payment like a telemedicine visit. So that's my understanding. It's not to exclude the opportunity for people to have the phone access. They can still have it, and whatever the negotiated rates are for a phone call discussion will all still continue, obviously. So any other comments on that?
This is Howard. I would agree with you, like that's the intent, is not to take away phone calls an option, but to exclude it from the payment parity portion of the proposal.
Yeah, because otherwise, if we include it, it won't be fair to the payer, obviously. So that we don't have any misunderstanding or misinterpretation of the intent. The access should still remain. The parity should not be the same as telemedicine, which is supposedly higher than a phone call. So that way it keeps the payer's side covered. So if that's understood, so if maybe we want to clarify, in the payment parity, phone calls are not a part of the payment parity, but not denying access by phone.
So Sarah, could you just clarify it in the notes then there, Sarah, that phone calls are, we want to preserve phone calls as an access. Thank you.
Okay.
Okay.
So I think we have spent, which was good, a pretty good bit of time and deliberated at length. So I would request that we call for a vote. Obviously, the chair will vote at the end after everybody has voted. So could we take a vote by raising the hands and identifying yourself also who's raising the hand for the record, please? Sarah, could you monitor that?
Sure, Mr. Chair, I just want, just for clarity purposes, is this commission voting on all of the provisions that we have identified here? So the main goal being to promote increased patient access to high quality care while reducing costs and improving patient and provider safety through the inclusion of clear, effective, and sustainable telemedicine language in Nevada revised statute. So that being your main goal, and then these are the other topics we want to make sure we capture. Is that what we're moving forward with?
I think we are capturing the telemedicine access plus parity of payment.
So not the regulations or these other items. Is my screen still showing?
Mason, could you comment on that? Which of these, in your opinion and your thought, was relevant to telemedicine part of it? Like ensure that there is sufficient access to technology and connectivity, which is a part, in my view, of telemedicine, obviously. So items in that list are relevant to telemedicine.
Right.
For the single subject BDR, we can incorporate, if everybody agrees with that. Those that are not directly related to that, one can look at it in a bill, another bill draft. Perhaps mental health is mentioned that, and if it's consensus of people, the parity of payment is not just primary care physicians, but mental health. That could be looked at also from the other suggestions. Mason, you have any thoughts?
Thank you, Mr. Chair. And I was going back and reviewed all the other input from the commissioners, and I think it captures the spirit of what the dialogue and then what everybody took the time to put their thoughts on paper in regards to telehealth. And so I think we've done a good job at least creating some framework here and moving forward. But I did thought a lot about what Commissioner Schoner said about big picture and not getting too bogged down. I'd like to maybe ask him a little through you, because it captures some of his thoughts on being a little bit bigger picture. And again, I think we're very fortunate in some of the communities that we live in that we do have technology and infrastructure, but I really wanted to stress and highlight the rural areas because it's been very beneficial during this time, especially for them to be able to link in for providers and subspecialists. And again, going back to what I've heard from the public comment from the beginning, there's always been somebody that's commented regards to telehealth and how efficient and being able to access that even during quarantine periods. So I think it does. And as looking at other comments from the commissioners, it captures their thoughts as well.
Okay, any other comments? Because my personal thought was item A is pretty general and straightforward, captures the general thought process. And then the second one is the issue of parity and phone call, etc. That is the one we are focusing on. The other items under Mason's recommendation, other than the efficient access to technology and connectivity to support telemedicine in rural Nevada, perhaps that should be added from this item to the main subject of parity, if everybody's okay with that. Anybody disagrees with that, to take that portion also as a part of what we are talking about with parity?
Could you repeat that, Chair Kahn? I'm sorry.
Yeah, it says that ensure that there is sufficient access to technology and connectivity to support telemedicine in rural Nevada, which I think is important for all of us.
And how does that relate to parity? You're just...
No, it's a part of a telemedicine access over there, because if they don't have access, then the question of parity doesn't apply to them. it at least ensures that there'll be effort made to at least have access to that and connectivity. So then the second phase of parity would already be in place because the rural physicians are already scarce. And I'm sure that will help them with the parity if they have access to telemedicine. So,
Mr. Chair, if I can just interject right here. So it looks like what we are all deciding to vote on is just what I'm highlighting, these items only.
yeah,
at
could
this
you
time.
please look at those and then we can move to the next step.
Okay, so it looks like there's a decent amount of commissioners. And Bobette first.
Yeah, can you hear me still? I lost my own screen. I think we should add Yulanis, I can't say anybody's name right, to this, which was that this should be evaluated, that we should be tracking how much telehealth works once these legislative efforts succeed. So I think we should review the results of telehealth utilization in state. Other than that, I'm good.
Okay, thanks, Bobette.
Teresa?
On number 3, ensure there's sufficient access. I'm kind of struggling with this because I don't know how much capacity the state's going to have to do this, but I also kind of issue with just focusing on rural Nevada. I think it's a little short-sighted to assume that it's only people in rural Nevada that have, you know, access issues to technology. So I would suggest that we change that to say, just to sort of end there, and then to say, you know, to take special, I don't know, to also include rural Nevada. I mean, maybe just have it just be Nevada, because I think that these issues you can be in Las Vegas and have access issues.
So if I may comment, you have a good point. So we can say Nevada in general, and we can say more specifically rural Nevada, because that's where the bigger challenge is. So that covers your point of Nevada in general for access, availability, etc. More specifically for the rural areas. Would that be sufficient? Okay, thank you. So any other comments before we take a vote?
Jessica?
Yeah, I just wanted to ensure, I guess this mental health piece gets up in there. You know, we were talking about parity, and there's 2 different types of parity we're talking about, right? Like parity for telehealth and in-person payment, but then also for mental health, you know, are we looking at mental health parity, or how do we expand services? I don't know if other commissioners want to talk about that, but I just would hate to see that getting left behind. So mental health services for telehealth, increased access to mental health services using telehealth is kind of the topic I'm passionate about. And I don't know what that would look like, if any other commissioners have thoughts.
So I think in that same item number 3 that we included Nevada and specifically rural areas, we can probably incorporate mental health in that language for access, availability, etc. To mental health technologically.
Thank you so much, Mr. Chair.
So I think if there are no more comments, we can call for a vote.
One comment.
I have a comment. Dr.
Sure.
Sure.
2 more. Sean first, and then Lenny.
Thank you, Sarah. Thank you, Mr. Chair. You can tell me that it's in violation of the single subject rule, but as we stare and think of access and to the comments regarding number 2 on participating with the licensure, I think back to the presentation that was made with respect, I think it was Arizona, that would allow a 1-year provisional license for somebody coming in from another state while that physician or provider works on getting licensed here in Nevada. Is there a reason why we would specifically exclude that from this? Or I think that's an important provision with respect to increasing access in this state to issue that provisional license for that year time period. As Dr. Barron has said many times over, you have to get licensed and then you have to go get credentialed. Credentialing doesn't happen until you get licensed. So if at least day 1, the providers are coming in licensed, it would help the credentialing process move through quicker. I don't want to limit that to just telemedicine services though, but I at least thought I'd point that out here to say that's an important provision. My hope is that we pick it up elsewhere if we don't plan to then at least put it in this language here.
So Sean, appreciate that. So you obviously bring a very strong point. We have talked about it several times, and personally, I am all for it across all boards, dental, et cetera, if that can be made easier depending how it is. But perhaps given the restriction of one subject per BDR, we have options for 2 other BDRs, and we could probably incorporate that component in our subsequent discussions, if that's okay.
Yes, that's fine. I at least wanted to bring it up. So thank you very much.
Thanks. Who else is in the line, Sarah?
Yarleni.
Okay, thank you, Sarah. Thank you, Dr. Kahn. Okay, so I believe that all the provisions that we have added, all the commissioners have added their opinion on things that should be in this telehealth bill. My question is, why are we limiting the topics that Sarah can go ahead and review with legal and change the wording? I don't think that we have a limit on what we can add into this bill, as long as it connects to telehealth. At least that's my understanding. And I believe that all of these provisions have something to do with telehealth, and they're just specific things that we all believe should be added into the bill related to telehealth. So my vote would be to go ahead and move on with the whole recommendation for Sarah to go and expand with legal and whatever people that she needs to talk to, and then present it to us on the next meeting. And if we need to adjust or take out things that we as a commission don't agree with, and then once we review the NRS, then we can vote on what we want to do. But I think we should just add everything, and she can adjust the language, as long as it, because it all pertains to telehealth. It's my opinion.
So specifically, what else are you looking for adding to whatever we have already in that component on telehealth?
I think all the provisions should be, everything that's written there has been provided by the commissioners. So I think it should just stay, and then Sarah can fine tune it to the bill.
So any other, because a lot of these items, broadband access is already in a way considered in that component of Nevada and rural areas. And health literacy for patients is a separate subject that's across the board, not just telemedicine, which is crucial also. And cultural competency to providers is also a cultural training, etc. That's just across the board, not just telehealth, as I understand this. And equal access is an access challenge that we have to address, as access for patients to get care and services, mental and otherwise. So that's the way I'm looking at it. So maybe in the next area, some of these subjects will also be covered.
Mr. Chair, if I may interject, just maybe if I can help. I think Yarleni is correct that I think what she's looking at is doing something like this, where you're dropping everything down into under telemedicine provisions. If I think that's what you're asking for, Yarleni, is then to take these out from here and move them under telemedicine provisions specifically.
Correct. Yes.
Is there any thought on that? Because what will happen then, as I understand it, is that this will go to the language drafters, and they can sift out things that this is not relevant, this will become another subject, etc. And obviously it'll all come back to us for our final fine tuning anyway.
Correct.
Right. I could certainly move it all under telemedicine provisions, and then work in between the meetings to make sure that I capture everybody's intent correctly, and then come back in front of this body with another proposed draft of this potential bill draft request for you all to continue deliberations on. If that pleases the commission, I can certainly do that, and that's enough direction for me for our next meeting. And then I know that's going to be addressed later on in the meeting, but what I would add to that is that if this is the intent, then you would also have a discussion on necessary presentations to make sure that you're deliberating on specific items related to these provisions to kind of enhance your narrowing down the language.
And thank you for that, Sarah. I really would like to proceed with the vote call because it's past 11:15. We have more areas to cover. So perhaps we can have like a roll call, individual people saying yes or no for what we are seeing on our screens. Could we proceed? Is Leslie going to do it or Sarah, you going to do it?
So
Sure.
This is Greg. Just
There you
if
go.
we're going to have a vote, I just like to either have a motion or some clear language as to what we're voting on and what the effect of the vote will be so that the record is clear, because there's been a lot of discussion about the effect of the vote.
Sure. Thank you for that. So can we entertain a motion for the language as presented to move for?
This is Tony Slonim. I'll move to move forward the bill draft request on telehealth with the mentioned regulations so that we can hopefully accept and advance this work to our next meeting.
Thank you. Is there a second?
This is Mason Van Houweling. I'll second the motion presented by Dr. Slonim.
Okay, thank you. So the motion is on the table. We can call for the vote then. We have already discussed at length. So can we call for the vote, Sarah?
Yep. Leslie, could you call for the vote, please?
Yes. Dr. Barron,
I agree. Yes.
Teresa Bohannon,
Agree.
Babette Bond,
Yes.
Jessica Flood,
Yes.
Flo Kahn,
Yes.
Dr. Packham,
Yes.
Yarleni Roa Dugan,
Yes.
Sean Shaner,
Yes.
Dr. Slonim,
Yes.
Mason Van Houweling,
Aye, yes.
and Dr. Kahn.
Yes. So the motion carries. I'm very appreciative and really grateful for all the commissioners for this pretty exhaustive deliberation. And at least we have come to a consensus to get moving to the next step on this language and fine tuning it so that we can get a bill draft going the sooner the better. So in the interest of time, our next item on the agenda, or did I lose track of my agenda here? So the other one, for possible action, we were on item 7, potential bill draft relating to healthcare to enhance patients' healthcare experience and state outcomes of implementing transparency measures that help understand data trends. So we have had a lot of discussion on the subject of transparency. And obviously, as I said earlier, this is a Pandora's box. What does each one of us believe is transparency, and transparency in what specific areas that, in my way of thinking, directly impacts patients' access to care and patient care itself and services for this patient that may be made available through some transparent measures that can be monitored. So with that said, we may want to, since there is no clarity, each one may have a different understanding on transparency. I may suggest if we can individually say what we believe in transparency we want to see, 1, 2, 3, and then if everybody can chime in their understanding of transparency in which areas, then we can narrow that discussion down to some more narrow discussion, if that's okay. So maybe we can go same process, Sarah, if everybody has a chance to speak and then another chance to speak, and then we can take questions if there are additional questions after that. So Sarah, could you please follow through the presentations? Who wants to speak next?
Sure. I don't know if there is an appetite for everyone to raise their hand, or if I'm just going to go down the first list that I see here. Maybe it's just for
Whatever
okay.
was practically good. Everybody should
Sure.
have it.
Sure. Okay, Bobette.
Thank you, Sarah. Thank you, commissioners. My version of what we should be focusing on as a commission in transparency is access to the kind of healthcare information that we either don't have in Nevada and have in other states, or that we don't have located in a way that you can easily find it in Nevada. And I went back to the presentation by Jamie King, where I thought that she did a really good job of talking about the primary reason why the US spends more on healthcare than any other country is price. And so I think price and access are tied. So what I'd like to push forward is the idea that we would create more available data to understand what are the trends contributing to price increases and how does that impact access. And that is sort of the focus of what Jamie was talking about. So my specific proposals don't exactly match what's here. I would like us to consider transparency in studying industry consolidation. When the physician groups are consolidating around a few providers, when the practices are being bought by hospitals, when there's mergers that change the market, those are all things that change the market. Those are things that we don't have much insight into in Nevada. We kind of know it if we're in part of the industry, but you don't know it from the outside, and we don't track the impact that it has on access or price. So specifically, market changes in the industry that change who owns. I think a related thing is the private equity money that's come into Nevada. There's 2 physician groups that are owned by private equity now, and it's having an impact on access and price, and we don't track that at all. So that would be an example. So I think market changes is one piece of transparency that I would like to see. In addition, I would like us to consider how we get better data about the price of prescription drugs. For example, we have diabetes and asthma legislation on the books, where if one of those drugs, those essential drugs, has an increase in price over a certain amount, it gets tracked and reported. I don't totally agree with what's being called a trade secret right now, but at least those data are coming in. It doesn't happen for other drugs. So I'd like to expand the list of drugs that we could look at the data for. Hospitals, we see a lot about hospital bill charges. We don't see very much about hospital prices. And as you could see from the data that was presented about emergency room visits, Reno's emergency room visits in Jamie's slideshow are half in terms of the trend increase as Las Vegas. Las Vegas emergency room visits have doubled. Why is that? So we have a lot of trends that we don't know why they're happening. And so I would say that I would like to see the bill be broad enough that we can take a look at these issues. I'll leave it at that because I know there's a bunch of input from others.
Thanks, Bobette. Who's next, Sarah?
Jessica?
Yeah, I just wanted to point out or highlight Flo or Commissioner Kahn's thoughts on transparency. She talks about establishing a board that looks at the total health cost of healthcare in Nevada. I think it could be more of a study, but and that could be legislated, right? So the board would include representatives from each sector, include cost data and policy recommendations. So one piece that would, I think if we could look at like having a study that actually looks at all pieces of the healthcare system. So there's the hospitals, but also the insurance agencies, all these different pieces, and really trying to get an understanding of Nevada's healthcare system, which I think Commissioner Slonim has talked about as well.
Thank you. Next in line. Sarah, who do you have next?
Well, Slonim, Dr. Slonim.
Yes, thank you. I agree with Commissioner Flood. I think that we have a lot of data out there. I'm not sure that the data are appropriately organized for us to take the next step. So I would love an opportunity to inventory some of the data and understand as a first step for advancing our world of transparency more broadly. I think, and again, it has to be across the industry. Hospitals provide lots of data, financial data, volume data, lots of data. I'd love to see, as Commissioner Bond said, pharma data, insurance data. We cannot eliminate segments of the industry if we're going to do this in a thorough way. So but for one step in the right direction, I'd love to see an inventory or a gap analysis for what's available and what we need to do next. Thank you.
Thank you.
Dr. Barrett?
Right. One of the things that has been brought up with our presentation from Jamie King was, an all-payer claims database, and we heard some discussion earlier this morning about the potential weakness in that, and that it maybe only applies to 70% of covered Nevadans. But as somebody who sits on the Network Adequacy Advisory Council, which really only covers 7% of the insured in Nevada, 70% sounds like a really good number to me. And so despite the fact that the ERISA plans would not necessarily be participating in a APCD type of a thing, I think that there's some value to that. I know that that there's some really good potential data that can come out of such a database. For example, Lenny mentioned, being able to go back and see whether some of the provisions that we put into statute for telehealth really do work. So how do you measure something like that? Well, one of the ways you can measure it is, did we cut down the number of unannounced emergency room visits for non-emergent conditions? If you had an all-payer claims database, you could see whether or not the number of paid out charges for ER visits correlated in any way, positive or negative, to an increase in telehealth provisions going forward. And while it's not perfect by any means, and you can draw different conclusions from the data, I think it's a place to start. And so I would certainly like to see the Commission consider the all-payer claims database idea as a first step in trying to clarify or start to get some of the data that we're looking for. And certainly there's other ways to get that as well. This could also move us forward a little bit in terms of quality measures, and see whether or not there are practitioners or institutions or whatever that are far afield cost-wise, but outcomes are substantially unchanged from the less expensive options and things like that. So again, there's lots of intervening variables and things like that, and I understand all of that as somebody who does quality improvement research. But on the other hand, at least it's a first step. So the APCD idea is something that I certainly like.
Thanks, Howard. We have a next commissioner.
Sean?
Thank you, Mr. Chair. I think the one thing that I want to stress would be that whatever we end up putting together with respect to transparency should provide some protection against the disclosure of proprietary information. That's something that I'm particularly sensitive to. I know Dr. Kahn, Chairman Kahn, made a statement last meeting around protecting proprietary information. So I want to make sure that whatever we put together, that we're looking to protect that information that is confidential and or proprietary in terms of certain reimbursement rates that are provided. And the all-payer claims database, to Dr. Barron's point, quite a few participate in it, but depending upon what information is presented, others who don't participate in it could use it to their advantage to the detriment of others. Don't want it to be seen as a way or an avenue for competitive information to be out in the marketplace that in no way protects consumers. As insurance companies' rates have to be filed with the Nevada Department of Insurance for individual and small group on a regular basis, they're either approved or denied. And the insurance industry is a very heavily regulated industry as it is. And I just want to make sure whatever we put out there just protects certain information that would otherwise be deemed confidential.
Thank you, Sean. I have the next commissioner.
Flo?
Thank you, Sarah. Thank you, Dr. Kahn. I agree. I think an all payers claim database is a good starting point. Certainly, you know, we would argue that there are flaws within that database, but we could work to address some of those shortcomings, particularly with respect to some of the rebates and discounts that are provided. But as I put in my work plan with respect to transparency, it does need to be holistic. I think that was a big part of the governor's push on this commission, is that we need to look across the board at all aspects of the healthcare system to determine what are the true cost drivers within the system. If you're just looking at a silo, that doesn't give you an accurate picture of where cost drivers are. And then in terms of, I agree wholeheartedly with what Sean's comments about proprietary data. I understand that there may be a difference of opinion on this commission about what constitutes proprietary data, but that is something that is incredibly important, because we don't want to take action that's going to have unintended consequences that's going to lead to higher healthcare costs. And then finally, one of the things that I've really been pushing is we shouldn't just be doing things for the sake of doing things to present that we're having transparency. It really needs to have the patient focused in mind and have a true outcome and benefit to the patients. And so those were the components that I suggested. There are a number of different ways you can do this. Certainly the all payers claims database is something that's already being done in 19 other states. There's some clear models. Our last speaker, or presenter, I should say, alluded to some of the ones that were working well, but there's other ways to do it as well. We can look at looking at creating a board, as Jessica mentioned, that I put in, that encompasses all the aspects of the healthcare plan or of the healthcare space, and collecting data and making policy recommendations. So I think there are choices. I think the easiest is all payers claims database.
Thank you. Have our next commissioner.
Dr. Packham?
Yeah, I'm in agreement with a lot of what's been said, particularly Howard's comments. I would not really favor the creation of a new price commissioner board, but rather have us think about if we were to pursue the all payer claims database to bake into it somehow some regular reporting requirements, including once or twice to this commission in the course of a year, to the governor by October 1st, to the statutory committees on healthcare. I think there's a lot of bodies, including the PPC, but not limited to us, that would be interested in that. And that just regular reporting requirements with that data would suffice.
Thanks, John. You have next commissioner.
Okay, Yarleni.
Okay, thank you, Sarah. Thank you, Dr. Kahn. So I agree with all the comments that the previous commissioners have said. And I would suggest that to be more proactive, could we do the same thing we did with the previous bill draft, where we can look and then write down what we are all commenting, so we can start narrowing down our ideas instead of just commenting. And I would like to add that I think for what I hear, we all agree on the transparency measures and creating the all payer claims database, or that it already exists, but making sure that it will monitor pricing for healthcare components, all payer claims, drug costs, hospital prices, healthcare entity ownership and merges, consolidation, closures, and governance for healthcare entities. So creating the board, I am not aware of how many other advisory boards already exist that are trying to do this, but I like the idea of Dr. Sloaning making sure that all this data is analyzed by somebody, creating a gap analysis. But who's going to do this? Creating a board sounds like a good idea, but I don't know if there's already that body already exists that can do that for us. I think right now we should mandate the reporting of data to the state of Nevada to include all of this to be analyzed.
Thank you. We have a next commissioner in line.
Sure. Mr. Chair, if I may too, I believe we've heard from everybody. I don't think that there's anyone that we haven't heard from. And at this point, we're just going to go back into additional comments from commissioners. But to Ms. Yarleni's point, I'm ready to share my screen. I've captured, I believe, what everyone has suggested. So you could start having a deeper deliberation on some of these items. So if it's okay with you, I'll share my screen now and then open it up to commissioners who want to speak again.
So that would be helpful. That'll hopefully help all of us kind of see what's the commonalities and see if we agree with some of those, and at least some narrows things down a little bit more specifically if possible. So we can go through a second round of comments or questions on views of what we have discussed so far. So I would hope everybody would participate and give any additional thoughts they might have. Ideally would be to narrow things down if we have some thoughts in our priorities individually, that this is what I would like to narrow things down so that right now we have a broad slate of generalized recommendations.
Okay, I'm just trying to figure this out. I will go back to Sean Shaner. Let me, while I figure out how to properly share my screen.
I think I'd rather reserve comments until maybe a little bit later on, if that's okay. I'd also want to just read what it is you have up here.
Sure. Can you guys confirm if you can see my screen or not? It looks a little bit different on my end, but can you see it all?
Yeah, I can.
Okay, great. So I don't know how it looks like. Now let's go back to, so Sean, I'm gonna then Jessica.
Sorry, from what I heard from Commissioner Whitley, they are purchasing an all-payer claims database already. And I think that he was offering that maybe it'd be worth it to have like a mandate to provide data into the all claims payer database. So if we could clarify what exactly that is, and maybe that happens later in this. And then, you know, going back to this idea of reviewing data and whatnot, I think what I was interested in Commissioner Kahn's comments, which she probably wasn't meaning it this way, but I think that we can legislate a study on the entire healthcare industry, if you will, because, you know, I've just seen people always say, oh, let's mandate, we're going to get data or get reports. And this just seems so complex for us to be able to understand what the data is saying and, you know, have the sophistication to really understand what's happening with the healthcare industry.
Mr. Chair, can I interject for one moment? I have something that I think I'd want this commission just to add to Jessica's comments.
Yep.
So this commission is a public commission. It's a statutorily created commission. It's permanent. So one of the things that you could recommend or think about instead of legislating or mandating a study, you could actually put in your recommendations for this body to be a part of a study, whether that's contracting with someone, whether it's going through your own systematic review. That is what the intent of this commission was for. The authority to request bill draft requests is just one of the provisions of this commission, but you could certainly also, when you're thinking about this, suggest your own commission or suggest this commission instead of putting it into a legislative measure. So I would be remiss if I didn't highlight that.
Okay, just to clarify on that. So you're saying that I understand that we can say we are going to conduct a study. I just don't know if this commission has the bandwidth to conduct that study or funding to go through with the study. So I think that's the only reason I was thinking legislatively. You could even say that we are going to do a study on the healthcare that would then report to the Patient Protection Commission. And I think that's how you could probably secure funding for this study that would occur. And I know there's not much funding around, but it does seem like this is important to really get a broader understanding of what's happening in the healthcare system. But that
Thank
was thoughts.
Okay, how about our next commissioner?
Okay, Teresa?
Thank you. So I like the idea of transparency. I see this more as a long-term strategy for improving outcomes for patients. I don't think if you went and polled a patient any day right now, if this would be the top of their priority. So I do see this as more of a long-term. I think when you get into the idea of boards and commissions and studies, that's where we kind of get lost. And I think at the end of the day, the real question is, so what? So what that certain providers or hospitals or whatever are charging more? If you need that care, you need that care. So I guess what is going to be the teeth involved in this? What's going to be the enforcement if we do find that there are certain industries or certain sectors of the market that are charging too much, or, you know, people can't access certain drugs? I mean, I think that people can just, there's a lot of anecdotes out there that tell you that is the barrier. So what is another study? What is another board? What is that going to really accomplish if there's not enforcement and teeth associated with it? And that's my comment.
Thank you. We have a next commissioner.
Okay, back to Babette or Director Whitley. Did you have something? I'm sorry. Nope. Actually, okay, so it's back to Babette.
Thank you, Sarah. Thank you, commissioners. I think, let me go backwards. I think that what Commissioner Bonhan just said is sort of the point. We've had a lot of studies to Commissioner Flood's request and to Commissioner Kahn's request. There have been a lot of studies in the legislature over the years on healthcare costs and the factors in healthcare costs. And it always ends up with the legislature getting a report of recommendations. And then those recommendations have been almost never acted upon. Some of the exceptions are, we were able to get legislation going on prescription drug transparency. Some, but it's incomplete. We were able to get surprise bills addressed finally, which took years, over a decade. And the data is important to lead to the direction of what policies we need to do. If we never get the data, if we never corral it into one piece to see actual trends instead of, you know, line by lines, individual stories and complaints, if we don't see the data set, we can't create the policies. It's a stair step, and we don't have the data right now in a consistent way. So I believe that the Patient Protection Commission, one of the primary reasons for its creation, and one of the reasons that the governor talked about in our first meeting is exactly this. I believe that this commission should be the one overseeing the collection of data, the data analysis gap, and then the recommendations of policies to address the gaps that the commission finds. I think that the industry consolidation is kind of a slam dunk. I'm hearing support for the all patient database, all claims database, but the industry consolidation that Jamie King talked about, I would really like us to move forward on that. There is no data on that. So if we don't ever have data, how are we ever going to make changes, or how are we ever going to understand the price impact they're having? So I think this commission should be the commission that does it. I don't support another board or starting this whole process again. It took 2 years to get the Patient Protection Commission going. I don't support just another study that goes to the legislature that then will turn into recommendations that no one has time for. I believe that's why we exist. So what I would support, what I would like us to consider is create the bill draft that gives us whatever power we need to be able to move forward on the analysis of transparency, which is down in my second part of that. Create a specific request that we have access to industry consolidation that start to be tracked. That's a bill, that's a piece of work that doesn't happen anywhere else. And then together study through the gap analysis idea, an inventory of what else we do and don't have that's going to affect price. I guess those 4 would be my ask.
Thank you,
I know I'm
Bob.
not making it easy to work on this list, but I feel like we have to get started. And I feel like another study is going to delay that. And I feel like the board's primed to do this. And I feel like this is frankly our job.
Thanks, Bobette. We have next commissioner online.
Okay, looks like there isn't anyone else that wants to speak. And I just added what you just requested, which was this piece. Okay, Chair Kahn, I would ask for direction on where we'd like to go. I do not have any other commissioners who raised their hands.
So what I really would like to see is narrowing this down to a little bit more specific language based on everybody's input. There are certain areas, as I understand, we are all desirous of having a study in the various areas is one aspect of it, to get the data and see what's happening, how is it impacting, get the data, how mergers are impacting the delivery of service, care, access, etc. That was my general understanding. If not, I would love to hear if anybody has additional thoughts on that.
Okay, Teresa?
I mean, I completely agree with Commissioner Bond in terms of, continuously going through this process of studying. I think there's a wealth of information out there that can point to where the cost drivers are. Again, I get back to how does that really benefit the patient immediately. And I also kind of am thinking about this through the lens of the patient, like, can we create some sort of mechanism through this transparency of having a place that you can go that helps you sort of understand this information in a way that does benefit you, or like that when you're kind of the victim of this, that you have a place that you can go that's easy and accessible. Just having my own experience, I'm thinking about how hard it was to get out of network change to in network, and still being protected by the law, and the insurance company knew that, but then yet they still pushed forward. And so you kind of have to do all that advocacy on your own. So is there any way that we can think about having something in this transparency that is patient focused as well? Oh.
Okay. Jessica?
I wanted to say my concern with the data and the study is thinking about an independent type commission, because who is going to be that person that's going to distill the information in a way that is neutral, and that kind of one focus or another, and not putting the burden on the state, because I think you would hear from Richard that there might not be the capacity or the resources there to do something like that. So I'm thinking more of independent type body. If we were to move forward with that type of route.
All right.
So is it me now, Sarah?
Yes.
Okay, great. So yeah, just responding to some of this, I like, Commissioner Bond's idea about this commission being, the commission that oversees the input of data. I have just seen on a lot of boards that you're like, hey, I want data, and then no one knows what to do with the data or how to interpret the data. So I guess all I'm asking for with this study is that we have some expertise. And to Commissioner Bonahan's point as well, we don't want that bias, but it just seems like even when we were talking about transparency or these small pieces, we're not understanding this bigger piece. And to your point, Teresa, I think a big part of this, how does this benefit the patient, is we're trying to lower healthcare costs. I think that's the whole point. And if we could reduce costs, then we don't get these $30,000 bills for stuff that we don't understand. So that was just the one piece on the study. And then, shoot, I think I'm going to have to remember what I was going to say afterwards.
Chair Kahn, if I can, I think that it would be appropriate if I shared some additional information or at least reminded this commission about some other resources within this commission.
So can we move on?
Yes, could I take an opportunity just to mention something about this commission's resources? It relates to what Commissioner Flood just raised.
Please
so
do.
One of the items that I think, or one piece I think, Commissioner Flood, that I wanted to make sure this body is aware of is my ability as the executive director to contract with other folks to help with the charge of this commission. So the main charge of this commission being a systematic review of our healthcare system, and then, you know, everything that's outlined in statute, and then having the ability to request bill draft requests. So my authority to contract with outside folks is exactly for a study, for something like that. There's resources that has been allotted to this commission already. Although I lost funding, or I shouldn't say I lost funding, but there was a statewide freeze on our policy analyst because that position was really meant to kind of fulfill some of those deeper studies, or at least having kind of some access to some extra analytical work. This commission does have the ability for me to contract with folks, and I think we have some funding right now that we haven't utilized, and I was able to still maintain, and that's to the tune of like $25,000. It's not a lot, but that is something that is a resource to this commission. So I want to make sure when you're thinking about this and you're thinking about studies or other boards or oversight that you understand all the options that you have. And I just wanted to make sure I mentioned that resource to you as well.
Thank you for the clarification. And then just to wrap back around, could we hear from Commissioner Whitley on what his recommendation was on the all payer claims database? Because he had a pretty specific recommendation, I think.
Thanks. This is Richard. We're proceeding with actually obtaining an all payers claim database, and part of that is related to ensuring that we get pharmaceutical manufacturers reporting, and other states have utilized it. But what we don't have is the statutory requirement for participation by all payers, and that was the bill that was considered last session that was sponsored by Senator Spearman and didn't make it through, ran out of time at the end. And so it's the actual requirement to report in.
Thank you. You have other comments on this?
Hello?
Yeah.
Thank
Sarah,
you. Just in the interest of time, hello, can you hear me?
Yes.
Just in the interest of time, in terms of moving forward, it looks like from all of the work plan submittals that an all payers claims database, at least proposal, is supported by most to collect the data as a starting point. And I think that's important because we do need the data, which includes all aspects of the healthcare system, including prescription drugs. So I think that's a good starting point for us. And if there's consensus to move forward on, I think it would be good to get at least the start of a draft of that. There's some great, there's other states that have already done it. We heard that, in particular from our last speaker, that Maine was one of the ones that had a lot of components to it that was, particularly helpful. And so I'm just wondering, can we move forward on, getting at least a draft created that we can review?
Yeah, I'm all for it to get a draft language narrowed down on various commissioners' views and opinions as best as it can be incorporated regarding the data collection. And the question is who collects it, who pays for it is a whole different ball game. Whether the state wants to get it, they don't have any funding, whether they'll create something else to look into that. I don't think we as a commission are able to sort of dictate any of that part as who should pay or how it should be done. If there is a way to collect data, if we recommend that, then the state can decide or the legislature can decide how they go about collecting that data. If everybody is at least on this point in agreement, please let me know. If there is any dissent, let me know. This is just a beginning to get some consensus to narrow down some language for this bill draft under the assumed title of transparency subject as a starting point.
Dr. Slonim?
Go ahead.
Yes, thank you. It seems as though our need for data is an important piece of work. The need to establish studies, boards, oversights. It makes me wonder whether or not we actually know enough of what we need to know to be able to recommend a regulatory remedy for this. And whether or not we still have, it sounds like this is a longer term issue that we need to address. And certainly we have the bandwidth to have data come back within this group. And we still have not used any of our subcommittees or the potential for subcommittee work on a go forward basis that could review data, analyze data, improve and understand what gaps exist. I'm not sure that we're ready for the BVR, but even though it was a priority for many of us, I want to be really specific about what we're asking for here because it's unclear to me.
So if I may, you're absolutely right that this is long-term in my understanding also. However, since in our previous multiple meetings, every commissioner just about talked about one way or the other of transparency. And that's why when I opened the comments, I said it's a Pandora's box. We need to narrow down what do we really mean by transparency. And the consensus seems to be appearing that we want some claims data collected somehow. Yes, it is long-term, obviously, and not short-term. And perhaps if everybody agrees on this part, and Sarah can narrow some of this general language on that, but if we create that bill draft for this subject, then that's the only subject we'll do in this bill draft, second bill draft, if everybody wants that to be the case, even though it seems to be long-term. Unless we have something short-term that we like impacted, that we would like to incorporate in this opportunity for a bill draft. Any comments from commissioners? I mean, sorry, I haven't taken a break. I was hoping we'll wrap up by noon, but we are getting close. Hopefully it's okay with everybody.
Are you still calling on people?
Yes, please. Yes,
Sarah. Yarleni?
Thank you, Sarah. Thank you, Dr. Kahn. So I agree with Commissioner Flo. No, was it Flo? I don't remember. Who said that we should start doing the draft. And I agree with Dr. Kahn about moving along with giving our recommendations and voting to see if this is something that Sarah can take over and work on it. For what I heard, Director Wheatley, then we don't have to worry about the all payer claims database since it's already being purchased. So maybe we should concentrate on mandating reporting of the data. So then our commission, the PPC, can look at that data, and we could either create subcommittees or contract somebody to put all that data into information that we can understand.
Thank you. Any other comments from anybody else?
Sean?
Thank you, Sarah and Mr. Chair. I think Dr. Slonim said some good comments there around the complexity of this issue and perhaps not fully having vetted out or understanding everything we want or think we want with respect to transparency. It's such a broad spectrum of services. And perhaps instead of focusing on simply a bill draft that addresses the sole issue of transparency and what we want, don't want, which I feel like Dr. Kahn, Mr. Chairman Kahn, could go on for another 5 hours easily and run into the Golden Knights game. I'm wondering if we would structure it in such a way that looks at what our future responsibilities would be as a commission and how we want to go about addressing transparency, and whether that transparency be cost, whether that transparency be around mergers and acquisitions or private equity influence, or transparency around equity, or excuse me, access, I apologize. Perhaps we structure it in that way, because I know many of us have been appointed to 1 or 2 year seats. And, you know, I don't want us to think solely about what we have to do in the next month, but instead focus on what we should look at over the next 2, 3, 4, 10, however long this commission years is, however long this commission is in place. So I'm just wondering if we restructure it, the transparency component, in a different way.
Sean, do you have any, you mentioned that, but is it possible for you to narrow down those 3 areas you mentioned in your observation, to narrow it down?
Well, in terms of future, I just simply wrote down cost, and everybody has a different definition of what cost is. So I wouldn't pretend to know what everybody's definition is there. But it was the influences of private equity or mergers and acquisitions, and then access. How we go about narrowing them down, I would obviously open that up to the entire group, and more than welcome to that. But instead of just trying to ramrod something through on transparency, which again, I think needs to be vetted out, I think we also need to think to the future of what we want this commission to be, and how we want it to be addressing these items in the future. And maybe that's just the better approach, as opposed to trying to force something down.
Yes, thank you very much. Any other commissioners want to comment? And specifically, perhaps, as Sean has narrowed down in his way, his thought process of the cost definition, mergers and access, that narrows down a little bit more specifically. Perhaps if other commissioners have something to add to that, then at least we'll start moving in a direction.
Teresa?
Thank you. I agree with the last comment. I do feel like there's kind of this rush, and I understand all that. I guess I'm struggling. I want to go back to what Commissioner Flood said, addressing like my concern. And one of the reasons that you see these high costs in care is some people are just going to have higher costs in care. I mean, they have specialties that are higher risk populations, but some of it is because we have an uninsured population. And because they're uninsured, the people who are insured have higher costs associated with the care. And so again, I feel like this is a little ahead of where we should be. I feel like the focus, if you want access and affordable care, is to ensure that every citizen in Nevada has access to insurance. And that's why my proposal was that we put forth the public option, because that's what's going to drive down costs, is that the cost of care isn't going to have to be outrageous for some who have really good Cadillac plans versus Medicaid patients. And so I like the idea of transparency. I'm all for it. I think all the ideas put forward by everyone have been thoughtful and you know, great. But at the end of the day, if we still have a significant proportion of Nevadans who don't have access to care, we're going to see kind of these crazy numbers, because that's just kind of the name of the game right now in the market.
Thank you. Any other comments?
I'll leave one more back to you, Babette.
Thank you, commissioners. I don't think that's the name of the game in the market. I think the market's being driven by very specific forces, and whether you're a Medicaid patient or you have what you're calling a Cadillac plan that I don't even think those exist anymore, or you have an exchange plan, there's a limited number of providers. There is industry consolidation going on that's driving up those prices, and that is one reason prices are increasing. I would like to go back to what Sean said, though, because I think that there's a path here. I think there's a path in the interest of trying to get somewhere. I think that if we want to focus the proposal on figuring out cost, consolidation, and access, those are categories that I can totally agree with, and I think we'll all be able to get our concerns into one of those categories going forward. So I'd like to limit the scope per your request, Chairman Kahn. But I think that we should specifically be saying in this, to Sean's point, this should be the bill draft, that the PPC should serve as an entity to monitor transparency capacity and build transparency capacity along these three areas. And then the PPC should have a systematic review of healthcare data available to monitor price trends in Nevada. And I think that would get to what I'm hearing here today. And in addition, have the all-payer claims database, which seems to have majority support. And
So,
that would get us to a second BDR.
good. That's very helpful, Bobette. If I may suggest, in the interest of our time, at least we have made some headway, and the three items that Sean put out and that Bobette is generally in agreement with those, with the addition of a review about perhaps PPC should monitor, etc. If majority of us feel that's a good starting point, then maybe we can get started on that, and whether this should be a part of our bill draft, unless somebody has a differing opinion on these three items which have been elaborated by Babette, then maybe we can make some progress to get some consensus on this item, and that would be a huge progress. And if there are additional items come to our mind, although I think if you look at them, they cover pretty broad areas of everybody's concerns voiced, then we can move forward in narrowing down some language for further review. Do any commissioners have thoughts differently?
It looks like, so Dr. Barron?
No, I agree. I agree, Chairman Kahn, with what you're proposing. I was going to comment on Commissioner Bohannon's comments earlier with regard to the uninsured, driving the markets and so forth. I would agree in this particular case with Commissioner Bond that that's probably not the main driver of healthcare cost. It would be helpful for this commission to have a document, I believe, and Commissioner Richardson can probably speak to this, but there was a study, and I can't remember if it was the Lindsay study or Kaiser Family Foundation study on uninsured Nevadans remaining about a year ago. And I believe that the numbers are coming back to me. It was something like there was about 400,000 uninsured Nevadans, and of those, there was something like 150,000 that were still eligible for Medicaid on our expanded Medicaid rolls. There was another 70,000 or something like that were eligible for tax benefits if they had purchased an exchange plan, and the rest were undocumented citizens and so forth, and so I'm not sure that it might be helpful for this commission to know those numbers from that study so that we really know what portion of the population we're speaking about. But I would agree with what's being outlined and highlighted by Sarah right now on our screens and with Chairman Kahn about moving forward with at least those principles.
Thank you very much, Howard. Anybody else? So the data can be confirmed by Whitley, and Sarah can distribute it to us for a reference point on that at a later point. So once you, please, Richard, share it with Sarah, and then you can distribute, she can distribute to all the commissioners. So if everybody, please chime in on these 3 points elaborated as it is. If we have a consensus on that, number one, and number two, my question personally is that whether there is appetite to put this, once it's narrowed down, fine-tuned, hopefully by next meeting, whether the recommendation would be to include this in a bill draft opportunity we have, or hold it for some other time. So first, if everybody is in agreement with the general outline, if anybody disagrees, please raise your hand and let Sarah know. Otherwise, we'll go the discussion, take the bill draft part as a second part.
Okay, Jessica?
Yeah, so I think we're headed in the right direction. I'm in agreement with where we're headed. One thing is looking at the three things that were identified by Sean. I'd like to have it say all sectors of the healthcare industry. I think about like, so maybe you're right, Dr. Barron, about, you know, we have a very insignificant portion of Nevadans that are uninsured. We are, though, ranked pretty high in terms of our uninsured population compared to other states. But I think just looking even like at Medicaid, right? They're reimbursing at rates that are far below, most people would say, under like what it takes for healthcare costs. I think Nevada Medicaid has even said that, you know, they're usually like what, at half, they reimburse about half of what it would cost the healthcare provider. So all those pieces I just think are important to take into consideration.
Thank you. Any other comments? You recommended a suggestion rather to add one element. Sarah, did you capture that?
I did. And so Commissioner Flood, it looks like this is what you intended, correct? This one to highlight?
Yes.
Okay.
Yeah,
Yep.
thank you. Any other commissioner has any exclusions or additions? So then we can at least either have consensus or a vote to at least move forward to narrow this subject down for a further discussion. But having said that, then we have to also decide whether we are all in agreement or majority are in agreement to consider this as one of the options for a bill draft once it's fine-tuned.
Like Dr. Slonim. And
Thank you. A couple of quick comments. I think we're directionally moving in a great place, and appreciate everybody's input. I think the one question I have is whether or not, as a part of a BDR, the expanded authority of the PPC is a little bit self-serving, and just want to make sure that we're taking that in context. The other part of that I'm interested in is, just so I'm clear on the process, we're just recommending that this move forward, and we'll again talk about details at our next meeting. Is that accurate?
Yes, because it'll narrow down our discussion points and hopefully expedite our decision-making at the next time. If we want this to be a bill draft, then that can be fine-tuned with that in mind between Sarah and the AG's office or the Legislative Council Bureau, whoever can guide us how to narrow things down. So we are closer to narrowing things down for a BDR language.
Very good, thank you.
Any other comments? So if anybody is opposed, please let us know. Anyone?
Flo? Yeah, so I just wanted, as we're looking at this, and I think it was clarified in the last statement that the highlighted portions on the screen, it looks like to me the expanded authority of the Patient Protection Commission versus the all claims payer database, those would actually be under two different BDRs potentially. Voting to move forward with further discussion on all of the segments that were highlighted, correct? Because I just wondered if you could have both the expanded authority of the PPC and the all claims payer database in one BDR. I was just confused on that. So if it's just moving forward with having a discussion of all of the highlighted provisions, I'm fine with that. I just wasn't sure it could all be in one BDR.
Sarah, you want to comment?
yes, please. So I think that the answer is I'm going to just seek some counsel from our legal and legislative counsel just to determine that. But the way it's highlighted now, it would just be the one BDR. And so it would include this language or the attempt to include this expanded authority, if that's what this commission would like to proceed with, at least moving forward with that. And then I will report back on after I receive counsel.
So I really want to wrap it up. If anybody has any objection, please raise your hand. Otherwise, I would assume there is a consensus to move forward with what we have discussed.
Okay, and it looks like Commissioner Richardson.
Yeah, so it's not an objection. I just wanted to point out, if you're trying to, gather data, another piece of data that you might be able to pick up fairly easily is the hospital price transparency. issue. The Trump administration just put out a proposed rule to start gathering that data, but it would only go to CMS, which means that we'll never ever see it. But probably not, I should say. But if they're already gathering that data or the data is being required, it's sometimes easier to be able to have the hospitals then just supply you with the same information in your state. So since that particular one is in a proposed rule status, there's already language too that's sort of set up. So it's just something to think about because it'll be helpful in comparison that data against the all payer claims database.
Thank you very much. So I understand that everybody on consensus is on board for moving forward with this particular subject for further fine tuning and some preliminary bill draft type of language to fine tune it further before our next meeting if possible, and then we review it again and add or subtract things and then move forward. So, and with that said, moving forward, so our next item on the agenda, discussion of future meeting dates. Sarah, you want to let us know the date?
Yeah, let me just close this out if you don't mind. Let me see here, hold on. So we closed that, and so we've got consensus to move forward on that. And let's see here, if you want me to open up.
The next dates.
Yeah, so the next dates are August 17th and then the 31st.
Of August. Or the 30th.
Point of order, Mr. Chairman. Does our DAG need a motion and vote on moving forward with that second agenda item that we just got finished, just like we did with the telehealth one? Or is a statement of consensus enough?
The AG is online.
I'm here, Deputy Attorney General Greg Ott. So I'm okay with the general consensus as long as Sarah is aware of what needs to be done to move that forward. My main concern with the first one was there appeared to be a vote without a motion, and I just wanted to clarify what the intent of the vote was. So if Sarah is okay with the direction she's got on the second one, I'm okay without a vote.
Thank you. Does that answer your question, Howard?
Yes, thank
you. Okay. Thank you very much. So we've got the dates for the next meetings already. And then for possible potential agenda items, I guess if it is okay with all of the commissioners, if we have additional agenda items, ASAP, if we can share it with Sarah so that they can get incorporated into the agenda item next time. The only request I would have is if we can all expeditiously respond to our items so that she has some time to, you know, get prepared and narrow things down and make sure everybody, commissioners' understanding of their agenda item is the same as she was going to put it down in writing. Does that make sense?
Yes.
Okay, thank you. And then the next one is the same thing with the presentations for future meetings. I would suggest, as before, please send in your recommendations or suggestions, or even from the public, if anybody wants to have any presentations, then please share it with Sarah so she can put it all together, reconfirm with you folks and those individuals who are willing to make presentations at the next meeting. Ideally, they have to be presentations relevant to the subject item that we have just talked about. Basically, that would narrow things down so we move forward with the BDR. If we spend a lot of time on presentations alone, then the deliberations get a little shrunk, which I would like a more sort of vociferous discussion on subjects amongst the commissioners so we all come to some well-informed decisions. So if that is okay with everybody, please let me know. If not, but hearing other options. So our next item is the public comments. Sarah, we have some people in the ending public comments.
Sure. Okay, public, if you would like to speak during public testimony, this is your time. Please press *9 to raise your hand. And, oh, Mr. Chair, one moment. Actually, Mason, did you have something?
Yes, Sarah and Mr. Chair, if you don't mind, I'd just like to take a moment to just publicly thank our past chair, Dr. John Packham, for his leadership and kicking us off in the committee and getting us pointed in the right direction. So I just wanted to say thank you to Dr. Kahn for taking over, but also wanted to take the moment just to recognize Dr. Packham for his leadership and everything he's done for this state for so many years. So just wanted to say that.
Very well noted and very well mentioned, Mason. I'm in full agreement with that for the record. Thank you. So Sarah, back to our patients.
Looks like we don't have any public testimony at this moment, but if we can, we'll just turn to Leslie just to confirm that no written testimony has been submitted during our meeting.
No written testimony has been submitted.
Thank you. So if there is no public comment, I would entertain a motion to adjourn and a second.
Second, Mason Van Halen.
Thank you. So thank you, everybody. I really appreciate, I think we've made some progress today and hopefully make some more next time, but really appreciate everybody's time. Sorry, we went a little bit over 12 o'clock, but at least we had a goal. Thanks a million, everyone.
Thank you.
Thank you, Dr. Kahn.
Thank you.
Take care.